okay. So
Okay, I've seen it.
Do you see
It's
now?
not showing.
Oh, okay.
yeah,
Yes,
and
I
in
can
the
see.
in the participants list, there's recording by your name.
Okay, so it's recording. All right. Thank you.
All
Good
right,
evening,
over
everyone.
to you, Doc.
Good evening, consultants, seniors, and colleagues. We welcome everyone to this year's revision. As we could see on the page, we've shared the MCQs in Braunwald'S. For the first, about 160 questions have been allocated. We may be having other participants joining. That's why I've not shared the second part. When we are setting the list is completed, then we do the second part of the questions. We've also shared on the page the curriculum topics and also the guidelines presentation. So kindly note the day you are presenting. If for any reason you cannot make it or you want to swap with a colleague, kindly reach out so that we can make that arrangement early. Thank you very much. On that note, with permission from seniors, we kickstart our MCQs for today. So we start with question one. A 54-year-old African-American man with a history of hypertension and hypercholesterolemia undergoes a treadmill exercise test using the standard Bruce protocol. He stops at 11 minutes 14 seconds because of fatigue at a peak heart rate of 152 beats per minute and peak systolic blood pressure of 200 millimeters of mercury. The diastolic blood pressure declines by 5 millimeters of mercury during exercise. During recovery, the systolic blood pressure decreases to 15 millimeters of mercury below his pre-exercise pressure. There are no ischemic changes on the ECG. Which of the following is correct? So basically, this scenario is introducing us to treadmill stress tests. There are various modalities of treadmills various modalities of stress tests. It could be treadmill, or you can have a stress SPECT, or even cardiac MRI with stress, and other modalities of stress test. But this specifically is a treadmill stress test, and there are indications, contraindications, and for stress tests. We'll be talking about stress tests in one of the curriculum topics, so I will not want to go too much into it, but if there are questions, we can raise so that we discuss it, so that we can finish the MCQs in time as we plan to. So the Bruce protocol is one of the protocols used for the treadmill stress test. The other protocols, such as the Norton protocol and others. The Bruce protocol has 7 stages minus the rest phase, and each phase runs for 3 minutes. So, and if you look at this scenario, you notice that this patient was able to do the stress test for 11 minutes 14 seconds. So literally, this patient was within stage 4, because if you do the first 3 minutes for the 3 stages, that will be 9 minutes plus 3 minutes will give it a 12 minutes, which will be in the 4th stage. So this patient essentially has done or was within stage 4 when the stress test was stopped on account of fatigue. Now, the indication for this stress test was not stated, but a stress test can be done for several reasons. It could be assessing functional capacity. It could be for evaluating coronary artery disease, valvular heart disease, and arrhythmias. But in this case, it was not stated exactly the reason why the stress test was done. However, if you look at this patient, he's 54, he's a male, he has hypertension and high cholesterol. So this patient has significant, relatively at least, even though if you don't even calculate, moderate risk for coronary artery disease or intermediate risk. Now, the treadmill stress test, when you are doing a test, you want to do a test that has a relatively higher chance of giving a reliable interpretation, i.e., for example, the stress test is as good as the pretest probability of the test. If the pretest probability of a test is already low, then the likelihood of having a positive predictive value is already low. So for you to do a stress test, for example, specifically for coronary artery disease, it's recommended when your pretest probability is at least between 15% to 85%. So there are various tools of calculating a patient's pretest probability for coronary artery disease. There are various calculators that are available. The patient should have at least an intermediate risk for the person to benefit from the interpretation of a stress test. Now, for a stress test to qualify as adequate, the patient should achieve 85% of the maximum predicted heart rate. Now, the maximum predicted heart rate is calculated by subtracting the age from 200. So if you do that for this patient, you notice that the predicted heart rate should have been 166 beats per minute. And if you do the ratio, you notice that the patient had a percentage of at least 92%, 91.6% of the target heart rate if you use 152 divided by 166 times 100. So it's an adequate test for you to comment on. Stress test could be protocol based or based on limited by symptoms, or it could be sub-maximal. For example, a patient who has had an MI, you want to assess the functional capacity, you can determine that the patient has to achieve a peak heart rate of 70% and not the 85%, or METs of less than or equal to 5. So if it's less than 85%, then it's not an adequate test. So this patient achieved adequacy in terms of exceeding the maximum predicted heart rate. So if there were changes, we can actually determine whether those changes were due to significant exercise or not. So if you look at the first question, option A, he says his peak systolic blood pressure during exercise exceeds that normally observed. So the systolic pressure increases with stress test as we go along. However, there have been various definitions for what is defined as a hypertensive response to stress test. In this case, this patient had a systolic of 200. If you look at Braunwald'S, they use a cutoff of greater than 210 for men and 190 for women. Other references have used 215 over 100 for systolic and 150 for diastolic. Irrespective of whichever reference you are using, this patient is within the normal blood pressure response with respect to stress test, considering the fact that he actually exceeded his maximum predicted heart rate. So that will not be a correct option. Now, the second says the change in diastolic blood pressure during exercise is indicative of significant coronary artery disease. Typically, there is no significant change with your diastolic blood pressure during exercise. It either remains the same or it reduces marginally, mostly in younger people. But the significance of it is in terms of coronary artery disease has not been established. It's a reduction in the systolic blood pressure during exercise that is considered to be significant for coronary artery disease, specifically if it is greater than 10 millimeters of mercury. It's considered a significant test for suggestive of coronary artery disease. So the B will not be a true option. Now, if we go to the C says that the test is non-diagnostic owing to an inadequate peak heart rate, which I've already explained that this patient achieved the adequacy for this result to be considered adequate. So that would be wrong. And then the next option says the results are consistent with a low prognostic risk of coronary events. Now, this is a patient that, I said earlier, we don't know the indication why it was done, but let's assume it was for coronary artery disease, considering the line of questioning. So if you look at this patient was able to exceed his maximum predicted heart rate. He was able to achieve almost complete stage 4 of the Bush protocol, which will put his METs, if he had completed stage 4, to about 12.9, almost 13. If you use the calculation for his predicted, in terms of you want to predict the METs that he could have achieved by age, there are formulas that are available. Some propose, for example, for men, 18 minus into bracket 0.15 times the age. If you use that, it gives you the predicted METs for this man for age 54 to about 9.9. And 9.9 is literally within stage 3. And this is someone who exceeded that and went into stage 4. So it tells you that this patient has a very good functional capacity. And secondly, his exercise was not stopped because of necessarily a positive test for coronary artery disease, but because of fatigue, which is expected for someone his age to have exercised to that duration of on the Bruce protocol. So if you look at that, then this is not a patient who has significant risk for coronary artery disease and a coronary event. So the answer is likely D. Now let's go to the E. The post-exercise reduction in systolic blood pressure is suggestive of severe coronary artery disease. So the reduction in blood pressure, the significance is at the peak of exercise or during exercise, not during the recovery phase, and that makes it wrong. So the answer for question 1 is D. I'll pause here for contributions or any questions. In the absence of that, I'll continue to save time. So question.
Thank you.
Okay, please, someone was saying something.
No, I was saying thank you very much. Good explanation.
Thank you, sir. So question 2.
Dr. Eugene.
Yes, sir.
Let's just establish a system so that you won't be finding it difficult to call for response. Please, the moment the question is read and the answers finished up, if you have any contribution, you can unmute and speak, or he will assume we all understood it and he will move to the next question. So in case you don't have any response, just a sign that everybody understood it so that you can move to the next question.
Thank you, sir. Question 2. Which of the following statements regarding the second heart sound is true? Earlier closure of the pulmonary valve with inspiration results in physiological splitting of S2. And right bundle branch block results in widened splitting of S2. Paradoxical splitting of S2 is the auscultatory hallmark of ostium secundum ASD. Then fixed splitting of S2 is expected in patients with right ventricular electronically paced rhythm. Then E, severe pulmonary valvular stenosis is associated with loud PG. So this scenario is focusing on the second heart sound. And we all know the second heart sound is as a result of closure of the semilunar valves, the pulmonary valve and the aortic valve. However, physiologically, there is a delayed closure in the pulmonary valve relative to the aortic valve. Now, if you look at the first question, it says earlier closure of the pulmonary valve with inspiration results in physiological split of S2. So the pulmonary valve do not close earlier in inspiration. So in inspiration, there's a decrease in the intrathoracic pressure. And this reduction in intrathoracic pressure increases venous return to the heart, to the right. And that leads to an increased flow across the pulmonary valve. And that increased flow across the pulmonary valves leads to naturally a relative delay in the closure of the pulmonary valve relative to the aortic valve. And so you can, in inspiration, there's rather a delayed closure of the pulmonary valve and not an early closure. So that is wrong. Now, if you have a right bundle branch block, basically what is happening is that it means that your left ventricles will depolarize earlier than your right ventricle. So there's a delay in depolarization of the right ventricle. Now that delay in repolarization of the right ventricle leads to a delay in quotes in pumping right from the RV through the pulmonary vasculature. So, and therefore, what is going to happen is that it's literally going to accentuate that delay in closure of the pulmonary valve, because the delay in activation of the right ventricle leads to a delay in the right ventricular stroke volume, and therefore there will be a much more delay in the closure of the pulmonary valve. Whereas the left bundle has already activated the left ventricle and there has been flow through the LVOT through the aortic valve, and the aortic valve naturally closes before the pulmonary valve, and now you have it be more activated earlier because of the RBB. So rather, it will widen the physiological split that occurs. So B is the correct answer. Now, if you go to C, C says paradoxical splitting of the S2 is an auscultatory hallmark of an ostium secundum ASD. which is not a correct answer. Paradoxical splitting means that in this case, is the reverse that is occurring instead of the delayed closure of the pulmonary valve. We are having the pulmonary valve closing earlier than the aortic valve. So in osteosecondum ASD, it's primarily a left to right shunt. However, the shunt, either whether in diastole or systole, your shunt is occurring because the left atrial pressure, either diastole or systole, is higher than the right atrial pressure, and it's a shunt at the level of the atrium. So the shunt is always occurring, and that leads to an increased flow across the pulmonary valve, because essentially with a left to right shunt, it means that there is going to be an increased flow through the pulmonaries. And like we said, if there's increased flow through the pulmonaries, then it's going to accentuate that delay of closure of the pulmonary valve. But because ideally that delay closure is accentuated in inspiration because of the increased flow to the right, that is when in the physiological splitting is better appreciated in inspiration. However, in an ASD, osteosecondum ASD, where there's a left to right shunt, the volume load is there, constant, either with inspiration or without inspiration. And so that leads to the split being there, either in inspiration or inspiration, and either phase of the cardiac cycle, so it's fixed. So that it will not be paradoxical, but it will be a fixed split. And so that answers the D, making the D false, that fixed splitting of the S2 is expected in patients with right ventricular electronically paced rhythm. Now, when you pace the right ventricle, it's essentially like the person has a left bundle branch block. So the reverse of what happened for the right bundle branch block is what will happen. So if you are pacing the right ventricle, it means that you are going to activate the right ventricles before the left ventricles get activated. And so the flow goes through the pulmonaries, whereas there's a delay in the flow from the LV through the LVOT. So you're going to have more of the blood going through the pulmonaries. The pulmonaries will close earlier than the aorta. So you're going to have more of a paradoxical split in a right ventricularly electronically paced rhythm, because you're going to have more of an LBD. Now, when you look at E says severe pulmonary valve stenosis associated with a loud P2. In simple terms, the more pliable the valves are, and the more easily they close in terms of the recoil, makes the sound relatively louder. Now, if you have pulmonary stenosis, the valves are not pliable, so they can't open wide to actually shut to give you that loud sound indirectly. So severe pulmonary valvular stenosis should not give you a loud P2. It should rather reduce the P2. Thank you.
Thank you very much, Dr. Eugene. I don't know if I'm audible.
You are audible, but you sound a bit far.
Am I better now, please?
It's better now.
Okay. Thank you very much for your very clear explanation on all the options. Just my contribution on the paradoxical splits. Outside that the paradoxical split is a reversal. The normal split occurs during inspiration because of what you explained. But in paradoxical splits, outside the A2, the P2 closing before the A2, it occurs in expiration. So that is why it is a paradox. That's one of the qualities of a paradoxical split, not just a reversal in the closure of the A2 and P2, but also it occurs in expiration, not in inspiration. So that's just what I wanted to contribute to that discourse.
And thank you for the contribution. Well appreciated.
Thank you.
So question 3, a state-of-the-art blood test has been developed for rapid non-invasive diagnosis of coronary artery disease. The assay has a sensitivity of 90% and a specificity of 90% for the detection of at least one coronary stenosis of greater than 70%. In which of the following scenarios is the blood test likely to be of most value to the clinician. Please, a minute. I'm opening the door. A minute. Yeah, sorry, please, I'm back. So tests have things that define whether the test can be used to achieve whatever it wants to achieve. So a test will have sensitivity, will have specificity, will have accuracy, will have reliability. There will be a positive predictive value and a negative predictive value. So sensitivity is essentially if you are suspecting a group of people to have a disease, the sensitivity essentially tells you the ability of the test to pick those with the disease. Whereas the specificity is the ability of the test to pick those who do not have the disease. However, of the people that the test could pick, sometimes you may have some false positives. So then there's also what we call the positive predictive value, which essentially tells you that of those that your test was able to pick that they have the disease, how many of them actually did have it? And there's also what we call the negative predictive value, that of those that your test said they did not have the disease, how many of them actually did not have it? So these are some of the characteristics of a test. Screening tests tends to have very high sensitivities because you want to pick as many people that may have the disease. Whereas confirmatory tests tend to have relatively higher specificity compared to the sensitivity, because you want to be certain that if the test result is negative, then indeed it's negative. Now, if you go to the first option, it says a 29-year-old man with exertional chest pain who has no cardiac risk factors. So if there's likelihood of the person having the disease, then the positive predictive value of that test increases, i.e., if the prevalence of the disease is high in that population or is highly suspected, then the likelihood that a positive test will be actually positive is high. So if the pretest probability is low, then the likelihood that a positive test will be a false positive will be high. So we need to understand it in that context. So if you look at question A, the option A, you have a 29-year-old who is less than 40 years and has no known cardiac risk factors coming with exertional chest pain. Now, the test you are commenting on is a test that is picking up obstructive coronary artery disease, and not just obstructive coronary artery disease greater than 50%, but 70%, meaning that obstructive coronary artery disease that may require intervention or revascularization. So if you look at this patient's pretest probability is already low. So this assay will not be something that will be clinically beneficial for this patient. So that is a wrong option. Now, if you go to B says a 41-year-old asymptomatic premenopausal woman. She's above age 40, and we know above age 40 is a cardiovascular risk. However, the patient is asymptomatic and is also premenopausal woman. So her risk generally is also low, and therefore the likelihood of this test being beneficial in picking a disease that is greater than of 70% in this patient is very low. Then you go to C. C says a 78-year-old diabetic woman with exertional chest pain who underwent 2-vessel coronary stenting 6 weeks ago. So if the person is 78, is diabetic, and is postmenopausal, very high risk, and he has the established disease already because he has had 2-vessel disease and has received stenting. So this is a patient that already has an established disease. So the positive predictive value of this test in this patient is high. However, if you have any patient with a very high positive predictive value or high likelihood of a disease, then the negative predictive value will be low. However, the question is, with a patient who has had stenting and he had an established coronary artery disease and had a stent put in, even if your test gives you room for giving you a false negative, you are not willing to sacrifice that for that patient because the consequences will be dire. The same can be said of the E option, where you have a 68-year-old woman with chest discomfort at rest, accompanied by 2 millimeter ST elevation depression, ST depression in the inferior leads. So this patient, the likelihood of having, this is literally like a STEMI. So even though the test might have been beneficial in these patients, the risk of having a false negative and therefore not acting on it, that consequences will be dire. So in terms of clinical context and clinical benefits, the D will be the correct option because you have a 62-year-old man with exertional chest pain who has hypertension, this and two-pack per day history of smoking. Now, if you look at this patient's risk of cardiovascular disease is at least moderate. You understand? And it's an exertional chest pain. Yes, it could be angina. However, if you look at the CDE, the test will be beneficial in all of them. However, which one will give you the best value or the most value in this patient? And this is a patient who has an intermediate risk, a test with a relatively high sensitivity and a relatively good specificity will help you make a decision on the pathway to take. So the option here is D. Question 4. A memo is auscultated during routine examination of an 18-year-old asymptomatic college student at the second left intercostal space, close to the sternum. The memo is crescendo decrescendo. It's present throughout systole and diastole and peaks simultaneously with S2. It does not change with position or rotation of the head. Which of the following best describes this memo? So essentially, if you look at the description of the memo, going through systole and diastole is describing a continuous memo. And if you look at the area, the left second intercostal space, the commonest memo that comes into mind anytime we auscultate a patient with continuous memo in left second intercostal space is likely a patent ductus arteriosus. And the reason why the patent ductus arteriosus has a memo throughout both systole and at least into early to mid diastole, it may not run through the entire diastole, is because you have memos across pressure gradients. When it comes to the pathophysiology of memos, you need, not always, but one of the things that contribute to a memo is a pressure gradient. Now, the PDA we all know is a connection between the pulmonary and vasculature and the systemic, which is the aorta. And so, irrespective of the cycle, cardiac cycle, either in diastole or in systole, the pressures within the systemic circulation or the aortic circulation will be higher than that in the pulmonary circulation. And therefore, whether diastole or systole, the gradient will be there. And so there will be that chance to elicit the abnormal flow, turbulence flow, and the memo. And so that is why it's occurring in both systole and diastole. A memo, for example, that can be continuous, that can be confusing, is like a venous hum, but that can vary with head rotation. And if you look at it, it's clearly stated that there was no change in the position in the memo with position or rotation of the head. So if you go to option A, they said this is a continuous memo, most likely a venous hum. common head in adolescents, which is not the case here because it was clearly stated that there was no variability with position or rotation of the head. The B says that this is a continuous murmur resulting from mixed aortic valve disease. With mixed aortic valve disease, yes, you have a systolic component and a diastolic component, but it may not often be continuous, as you find in the patent ductus arteriosus. There isn't no distinction between the systolic component and the diastolic component clearly. But in a mixed aortic valve disease, you are likely going to have a distinction between the systolic component and the early diastolic components. And that may give you a clue that you are dealing with a mixed aortic valve disease. C says this is a continuous murmur due to congenital shunt, likely the PDA, which is what we've mentioned. It's been described as the machinery murmur, and I think they've also used the name Gibson's murmur. D says continuous murmur of this type can only be congenital. Murmurs due to acquired arteriovenous connections are purely systolic, which is not true. Because if you've examined an AV fistula before, it is not entirely the case. It also runs through both in systole and diastole based on the same principle, because the arterial system has a relatively higher pressure than the venous system, irrespective of the phase of the cardiac cycle. So it will run through both systole and diastole and to not just be purely systolic. Okay. Any contribution, please? In the absence of that, question 5. Unequal upper extremity arterial pulsations would be unlikely in which of the following disorders? So we are looking at differences in the pulsations in the upper limbs. Mostly clinically, when we examine, we tend to do radioradial synchrony, mainly for the upper limbs, looking for differential flow across the arterial systemic circulation that supply the limbs. And any difference may suggest a pathology of the arterial supply to that limb. Now, when you have an aortic dissection, essentially the upper limbs are supplied axillary artery, then it comes into the limb. So subclavian, axillary, then it goes into the various branches, brachial, radial, ulnar, etc. Now, if you have an aortic dissection, that affects the origin of the arteries that supply the limbs, the dissecting flap cutting off the origin of the artery, then that limb will preferentially have a reduced blood flow and therefore reduced palpable pulse clinically, or the pulse may be absent. So if you have a dissection taking off the origin of the left subclavian artery, for instance, then blood flow to the left upper limb will be compromised. So there will be a differential flow in terms of the artery, so arterial flow. Now, Takayasu disease, we all know, is a vasculitis that can affect large arteries, the aorta and its branches, and can also lead to, because it's inflammatory, the consequence of inflammation is to heal with fibrosis. And the fibrosis may be, it will not be uniform across the arterial system. So it can cause an asymmetry in terms of the narrowing, depending on the vessels that are involved, and can give you that asymmetry. Okay. Now, if you have a supravalvular aortic stenosis, now the supravalvular aortic stenosis and a subvalvular aortic stenosis, I will look at the two together. Now, if you look at the aortic valve and you have a stenosis before the aortic valve, let's say you have an apical 5-chamber view, and in the LVOT, there is a membrane across the LVOT before the valve. Clearly, that's a valve. So that definitely, the flow will not be differentially distributed. It will be the same. The reduction in flow will be the same in all limbs, because it means that the flow is not going even into the aortic valve the way you expect for it to come out of there as aortic, the ascending and arch. So it's unlikely that the subvalvular one is going to cause a differential a difference in the flow across the limb. However, in supravalvular aortic stenosis, you may have situations where there will be a differential flow into the brachiocephalic system. And so you may have relatively better flow in the right upper limb compared to the left upper limb. And that is why the correct answer here would be subvalvular aortic stenosis. Subclavian arterial atherosclerosis, obviously, if you have a lateral subclavian artery stenosis, then the limb that is supplied by that affected subclavian artery will have a reduction in the flow. So with question 5, the answer is E.
Dr. Eugene, thank you so much. Please, let me just also help out to pass an information across. Welcome everybody again. It's not just those that want to contribute. If any explanation is not clear to you, you can actually unmute your mic and request for the explanation to go for the person to go through it again. So let's not keep quiet in silence. As much as we want to gain speed, our interest is everybody should have an understanding of the basics of cardiology. So please, if you have questions to ask, you can unmute and ask. And if you have contributions to make, you can unmute and make them. Thank you so much, Dr. Eugene. Thank you, everyone.
And thank you, Dr. Kopi. Grateful. So in the absence of any contributions, questions, corrections, we'll go to question 6, which will be taken by Dr. Charles. Is Dr. Charles Okori on, please?
Good evening, everybody.
Good evening.
Yeah, I'm on. Good evening. All right. Thank you very much, Eugene. We'll go to question 6. It says a 58-year-old woman with metastatic breast cancer presents with exertional dyspnea and is found to have a large circumferential pericardial effusion, jugular venous distension. Okay, and is found to have a large circumferential pericardial effusion, jugular venous distension, and hypotension. Which of the following echocardiographic signs is likely present? Okay, from the question, we're looking at a 58-year-old woman with breast cancer with metastasis who presents with shortness of breath. Echo now shows a large effusion, a large pericardial effusion. She also has a raised JVP and a hypotension. Of course, this is in keeping with the Beck's triad. So they now ask which of the following echocardiographic signs is likely present. So the patient likely has cardiac tamponade. And in cardiac tamponade, some of the signs we can see include, of course, there will be a large pericardial effusion, although we know that most times in tamponade, it's not just about the size of the effusion, it's also about the rate of the accumulation. So a smaller effusion will cause tamponade if it accumulates quicker. Okay. Then part of the things we also see in tamponade is that we can see collapse of the chambers. Most times we can see collapse of the right atrium and the right ventricle, and this collapse usually occurs in diastole. Okay, there may also be left atrial collapse, although left atrial collapse is not common. Literature says it's seen in about 25%. And of course, LV collapse is very, very uncommon. This is because the left ventricle is a much more muscular chamber, so it's highly unlikely to collapse. And that thing we can see in tamponade on echo is respiratory variations in volumes and flow. Like we know, during inspiration, venous return increases, and the return to the right side usually increases. Therefore, the right heart volumes usually increase. Okay, when that happens, of course, this pressure will usually be transmitted to the pericardium. Okay, but because of tamponade, where it's not able to be transmitted to the pericardium, the pressure is now transmitted to the septum. Therefore, the septum now shifts towards the left. On echo, this manifests as an amplified respirophasic variations on mitral inflow. What I'm just trying to say is that in inspiration, there is a decrease in flow across the left-sided valves. So the mitral and aortic valve will have a decrease in flow, okay? And there will be an increase across the tricuspid valve. This is seen normally, okay, but this is exaggerated in tamponade. And this is, of course, the same phenomenon that causes pulsus paradoxus, because it is this exaggerated increase that causes an increase in the blood pressure that is peaked when we check pulsus paradoxus. Okay, so let's take the question. So it says, which of these echo signs is likely present? A collapse of the right ventricle throughout systole. Of course, no, that's not true. The collapse of the right ventricle happens in diastole. Okay, then the second one is exaggerated decrease in tricuspid inflow velocity during inspiration. Exaggerated decrease, sorry, in tricuspid inflow velocity during inspiration. That is also not true. The option C is exaggerated decrease in mitral inflow velocity during inspiration. Okay, so that's actually the correct option. There's an exaggerated decrease in mitral inflow velocity during inspiration. Option D says exaggerated increase in left ventricular outflow tract velocity during inspiration. It's the same thing that happens in the mitral valve. There's an exaggerated decrease in the LVOT velocity during inspiration. Then option E says markedly increased EA ratio of transmitral Doppler velocity profile. So that is also not correct. The correct answer is to option 6. Question 6 is option C. Okay. I don't know if there are any questions.
So please, I want to ask a question, sir. Thank you very much for your presentation. So I want to find out right ventricular or right atrial collapse, which is more specific or which is more sensitive?
Okay, I think specific answer. I'm not actually certain, but I think right atrial collapse is more sensitive. Why RV collapse is more specific. Yeah.
Yeah, Dr. Corey, you are correct.
RV
The right
collapse is
atrial
more
collapse
sensitive.
is more sensitive. Yeah.
And sorry, and that question, please, which one appears earlier?
RV collapse will appear earlier. The atrium will appear earlier than the ventricle.
The more sensitive indicator appears earlier. That's the right atrial collapse. It's a less muscular structure, so any pressure will cause the collapse. So that, and it can, just the way you know the definition of sensitivity. Sensitivity means picking up every possibility. So the right atrial collapse may occur without having true tamponade. So it can occur early, but the right ventricular collapse is more specific.
Thank you very much, sir.
Hello. Just for clarification, the right atrial collapse is not in diastole. The right atrial collapse is in systole, whereas the right ventricular collapse is in diastole.
You're right. Thank you again. Thank you, Dr. Eji, for that further input.
So sorry, just to confuse things a bit, following what Eugene said. So with the right atrial collapse, it depends on how they phrase it. If they just say in systole, then we assume it's ventricular systole, in which case it is actually in systole. But if the question says in atrial diastole, then it would be that rather than systole. Thank you.
Sorry, I'm not very clear about that, please.
The right atrial collapse occurs.
I think, okay.
Yes, the right atrial collapse occurs when the ventricle is contracting, right? So that is ventricular systole, at which point the atrium is in diastole. So then In if it's being said in terms of the atrium rather, then it will be atrial diastole. I don't know if that makes sense.
Yeah, it makes sense. But
It
what
makes
someone is
sense.
trying to say is that the examiners if we say systole, usually we are referring to the ventricular cycle. But the question may be twisted and they will qualify it in atrial diastole or atrial systole. So when they qualify it as in atrial systole, then you should know that it is wrong, but the right atrial collapse should be atrial diastole. So when we don't qualify it and we are just saying systole, we are referring to the ventricular systole. Basically, that's what the point is trying to alert us. Hello?
All right. Okay. I think we can.
We can go ahead,
Yes.
but let me just put
Any
a
more comments?
small announcement. Yes, comment please, small announcement across. Please, if we can rename our devices so that we can know the persons on the platform for some security reasons. So if your device is not fully named, we might end up removing you from the platform. Please just try rename it to the names we have on the WhatsApp page. Thank you.
Sorry, just to add, please, because in
All right,
minute,
thank you.
sorry, please, just to stay, I want to stay out, please. The right ventricular collapse, when does it occur? Is it in diastole or systole? Because I've seen some questions where it is said that it happens in diastole and early diastole. So please, can we just clarify, please?
The right ventricular collapse occurs in early diastole. Okay, when the right ventricular volume is still not as much. That's usually when it will collapse.
Okay. Thank
I
you
don't know
very much.
whether you get me. It's early diastole.
Yes, thank you very much. Thank you very much. And then the right atrial collapse is also diastole.
The right atrial
For
collapse is systole.
Is systole,
But that's
ventricular systole,
ventricular
if you want
systole.
to put it that way.
So look at the pathophysiology. The heart is filling in an enclosed space because of the tamponade or the massive pericardial effusion. So in diastole, your RV is supposed to fill. But because of that restriction of the volume in the pericardial space, the RV is trying to fill, but it doesn't have room, so it collapses when it is filling in diastole. Whereas for the atrium also is filling, but the atrium fills when there's ventricular what? The ventricle are contracting, ventricular systole. That is when the atrium is filling. So when the right atrium also is filling in ventricular systole, it needs that volume, that negative pressure within the pericardium to fill. But because it's filled with fluid, it collapses. You understand? So that is why the right ventricle is in diastole, whereas the atrial is in systole.
Please, if you need clarification, you need to say it up because this particular stuff almost always comes out in the exam. So thank you. There's nothing, Okorie, we can hit the ground running.
All right, thank you, sir. We'll move to question 7. And it says, which of the following statements about pulsus paradoxus is correct? Let me just take the options. It says, inspiration in normal individuals results in a decline of systolic arterial pressure up to 18 millimeters of mercury. B, accurate determination of pulsus paradoxus requires intra-arterial measurement. C, pulsus paradoxus is unlikely to be present in patients with advanced aortic regurgitation, even in the presence of tamponade. And D, pulsus paradoxus is common in patients with hypertrophic cardiomyopathy. Okay, like we know, we define pulsus paradoxus as an abnormally large decrease or an exaggerated decrease in the systolic blood pressure on inspiration. Okay, normally the blood pressure falls on inspiration, but this fall is not usually more than 8 to 10 millimeters of mercury. So when the fall is more than that, that's when we say we have pulsus paradoxus. It's called paradoxus because of course it's gotten by checking the blood pressure. Although the name actually comes from volumes. When you check the pulse and the volumes tend to increase in inspiration, that's actually how the name comes about. Okay, but how you check pulsus paradoxus practically is by using a sphygmomanometer. Okay, and you gradually decrease the or deflate the cough. Okay, listening in inspiration and in expiration. Listening, so just to gradually deflate the cough. Okay, you first of all get the you hear the cough sound in expiration, and you won't be hearing it in inspiration. So you just mark it and you gradually deflate it. That's how you get pulsus paradoxus. Another way to get pulsus paradoxus is actually to measure the blood pressure intraarterially. Intraarterial BP measurements will actually give you pulsus paradoxus. Another thing to know is that it's unlikely to have pulsus paradoxus in some certain conditions, even if they have conditions that can cause pulsus paradoxus. But there are some conditions where you're unlikely to have pulsus paradoxus. Let me just list them. One of them is chronic hypertension, okay, leading to high diastolic pressures or elevated right atrial pressures. It's difficult to get pulsus paradoxus. That's one. Two is if there's a coexistent atrial septal defect. And the next one is those with aortic regurgitation, even when there is tamponade. Okay, then let me just list causes of pulsus paradoxus, cardiac and non-cardiac causes. Cardiac causes, you have pericardial and non-pericardial causes. Pericardial causes include the commonest one is actually cardiac tamponade. The next one is constrictive pericarditis. Said pulsus paradoxus is seen in 1/3 of patients with constrictive pericarditis. The non-pericardial causes include things like right ventricular myocardial infarction and also restrictive cardiomyopathy, not hypertrophic like is in the question. Then the non-cardiac causes are mainly pulmonary causes, which include asthma, COPD, obstructive sleep apnea, pulmonary embolism, tension pneumothorax, bilateral pleural effusion. Then other causes include things like marked obesity, shock, hypovolemic shock, pectus excavatum, extrinsic cardiac compression, and I saw one source that mentioned pregnancy as a cause of pulsus paradoxus. So with this, we've answered all the questions, but let's just go through the options. Inspiration is in normal individuals results in a decline of systolic arterial pressure of up to 18. It's up to 8 to 10, so 18 is false. Accurate determination of pulsus paradoxus requires intra-arterial pressure measurement. That is false. You can use a SFIG to determine, but you cannot use an automatic SFIG to determine pulsus paradoxus. It has to be a manual SFIG. Pulsus paradoxus is unlikely to be present in patients with advanced aortic regurgitation, even in the presence of tamponade. That's actually the correct answer. Then D, pulsus paradoxus is common in patients with hypertrophic cardiomyopathy. That is also false. That's for question 7.
So I want to find the answer, sir.
All right. So, yeah, I didn't hear you.
Yeah, why is C the answer? Why is it in aortic regurg?
Okay. Why won't you have pulsus paradoxus in aortic regurgitation? I think the answer is because the large volume of blood coming back through the aortic valve in aortic regurgitation will serve to, because the main pathophysiology in pulsus paradoxus is actually it is not able to, because it is what we get in the heart that translates into is what we get in the LV that translates into the artery and into the pulse. Okay, so with that large volume of blood, you will not get that exaggerated increase. That's how I understood it. Okay, that will be reflected in the aorta and in the pulse. I don't know whether you get my point. It's the same thing when there is a high pressure in the left side. Okay, you will not be able to, the left side of the heart will not be able to attain that pressure to get that exaggerated decrease. I don't know whether you understand what I said. Maybe someone can put it better.
Yeah, so Dr. Corey, like you said, people with aortic regurgitation tend to have an increased left ventricular pressures than usual. Remember that you are hoping that that bulge in, let's say, a tamponade or in constrictive pericarditis, leading to a reduction in the left ventricular stroke volume, will indirectly cause the blood pressures to decrease. However, if the filling pressures are already elevated, that effects on the right having that effect on the left does not happen as expected because the ventricular pressures are already high on the left side to prevent that bulging significantly into the left to reduce that inflow into the left side. And also, like you mentioned, the end diastolic volumes are higher. So its effects is it makes the difference, it blunts that difference. So that may not translate clinically into that BP difference that will qualify for criteria for causes paradoxes.
Thank you so much. Thank you. Thank you. Thank you, Clara. All right, so I believe I can move on to question 8. 57-year-old man with a history of hypertension and elevated low-density lipoprotein cholesterol presents to the emergency room with the acute onset of substernal
Hello?
chest
Sorry.
pressure. It's like
Oh,
question is
sorry.
up. Yes, hello.
Please, yes, Dr. Charles Gray. Well done. Sorry, this is Dr. Rimolade.
Yes, I can hear you. Okay.
Yes, thank you. Thanks for that explanation. Then to now be also good to mention what we'll have in aortic regurgitation. What type of pulse are we going to have in aortic regurgitation? So it will be good to mention, just like you have said, and it's Corrigan, then the pulses by French. So instead of pulses alternate. I'm not sure if you understand what I'm trying to say.
No, I didn't get you, Chief. I didn't get you.
Yes, I said since we can't have pulses alternate even in the presence of tamponade now in aortic regurgitation, the ones that we can find, the pulse that we can find in aortic regurgitation might also be important for other MCQ questions. You mentioned the Corrigan pulse, so it will be two-peaked pulse, which is the pulses by Ferencz. I'm not sure if I'm audible.
Yes, I can hear you. I'm following.
Okay, thank you.
Thank you, Chief. Okay. I believe we can move to question 8. Thank you, Chief. So, a 57-year-old man with a history of hypertension and elevated low-density lipoprotein cholesterol presents to the emergency room with an acute onset of substernal chest pressure, dyspnea, and diaphoresis. His blood pressure is 158/96, and the heart rate is 92 beats per minute. Physical examination reveals clear lung fields and no cardiac gallop or murmurs. The ECG shows sinus reading with a prominent I wave in lead V2, 0.5 mm of ST elevation in lead 3, and 2 mm of horizontal ST depression in V1 to V3. Which of the following will be diagnostically useful to plan a course of action? Of course, we have a 57-year-old man with a significant history of hypertension and high cholesterol, who is presenting with an acute onset of what looks like an MI, chest pressure, dyspnea, diaphoresis, with a mildly elevated blood pressure. Heart rate is normal at 92. Okay, physical examination is just nothing much. The ECG is showing a sinus reading with prominent R wave in lead V2. There's a 0.5 mm of ST elevation in lead 3, which doesn't seem to be significant because it's 0.5 mm. But he has a 2 millimeters horizontal ST depression in in V1 to V3. Okay, I think looking at this question, the diagnostic dilemma here is to say, are we dealing with a STEMI? Are we dealing with an N STEMI? Okay, that's actually, I think that's what the question actually wants us to decide, whether it's a STEMI we are dealing with or an N STEMI, because both of them can actually present in this way that we are seeing. And knowing that patient has an ST depression in V1 to V3 with an elevation that doesn't seem so significant in lead 3. So we know that this could be a posterior, this is actually concerning a posterior STEMI. And to get a posterior STEMI, what we need to do is to put some leads, put posterior ECG leads, V7 to V9. Okay, so that's actually the right thing to do. So the option says repeat the ECG with right-sided precordial leads. Now you want to do right-sided precordial leads when you are looking at an inferior MI with right ventricular involvement. Okay, so that's when you want to do V1R, V2R, and V3R on the right side. Okay, so when you want to look at the right ventricle. Okay, so that's not what is the case here. So the answer is option B. Repeat the ECG with V7 to V9. You won't want to await results of serum cardiac biomarkers because this is an emergency. If you do that ECG and it is positive, you want to actually take him straight for coronary angiography and possible intervention. And of course, this is not pulmonary embolism, so you don't want to obtain a chest CT to assess for pulmonary embolism. So option B is the correct answer. Okay, question 9 says, which of the following combinations does not have the potential for significant pharmacologic interaction? Which of the following does not have the potential for significant pharmacologic interaction? Okay, this was actually a difficult question for me because looking at it, pharmacology. All right, but let's just go through the options. Option A, simvastatin and erythromycin. Combination of simvastatin with macrolides like erythromycin, clarithromycin, except azithromycin, has been shown to increase statin myopathy. Okay, so there's a significant interaction there. Of course, sildenafil and nitroglycerin. This one is common. Patients who are on nitrates should be told that they should not be on phosphodiesterase inhibitors because of the risk of profound hypotension. So that one is clear. So option B is not the answer. Option C, pravastatin and ketoconazole. Unlike the other statins, pravastatin is not metabolized by the cytochrome 3A4. So the increased risk of myopathy that is seen with simvastatin and atorvastatin is not seen in pravastatin. So it can actually be taken with drugs that with drugs like ketoconazole and even the macrolide. So that's why option C is the correct answer. Talking about cyclosporine and um, St. John's Wort. I can't remember what I wrote. Then let me just move to the next one while I think about that. Then the digoxin and verapamil. Verapamil inhibits the efflux of digoxin and it may contribute to digoxin toxicity. So it is not indicated. So digoxin and verapamil should not be combined. Okay. Then also St. John's wort is also a cytochrome inducer, so it will result in lower levels of cyclosporine. So that's why they should also not be combined. So the correct option is option C, pravastatin and ketoconazole. Okay, question 10 says it will be reasonable and safe to order a treadmill exercise stress test for a patient with which of the following conditions. I think they are testing our knowledge on the contraindications to exercise stress testing. A, symptomatic hypertrophic obstructive cardiomyopathy. B, advanced aortic stenosis. C, acute myocarditis. D, abdominal aortic aneurysm with a transverse diameter of 5.5 cm. And E, unstable angina. Okay, for A and B, in patients that have any form of LVOT obstruction, hypertrophic obstructive cardiomyopathy, or aortic stenosis, when you stress them, because you worsen it, and it will the because of the obstruction, the heart will be unable to increase cardiac output during exercise. So it's not indicated. Such patients should not undergo an exercise stress test. With acute myocarditis, there's an increased risk of death when they undergo stress tests. So such patients too should not undergo stress testing. Then the only condition here that you can undergo stress testing is when it's the abdominal aortic aneurysm with a transverse diameter of 5.5 cm. But it's important for us to note that if there is a dissection, stress testing is contraindicated. Then for unstable angina, there's no need to actually undergo if you know that this is unstable angina. You should take the person for, depending on the risk stratification, take the person for an angiography and treat accordingly. So the person should not undergo a stress test. The answer is option D, abdominal aortic aneurysm with a transverse diameter of 5.5 cm.
Dr. Perry,
Yes.
thank you so very much. I just wanted to add that in the investigation of aortic stenosis, there is room for stress testing. The catch here is that this one saying advanced suggests that it's probably severe, like a critical aortic stenosis, in which case you wouldn't. But if you have like a moderate aortic stenosis, especially if asymptomatic, and you want to know the hemodynamic significance, or someone who has a low flow, low gradient aortic stenosis, then these are some reasons where these are some instances where you may want to do a stress ECG. So when we see stress ECG and aortic stenosis in a question, we need to look closely to see whether it's just the severe form or it's like a mild to moderate. If it's mild to moderate, then a stress ECG could be indicated depending on what the question is looking for. Thank you.
Yeah, thank you so much. That's correct. Thank you. All right, if
Okay,
that
so
I'm done with so you take over.
I think
yes, in the absence of anything
continue.
else, I'll continue with my questions. Yes, so question 11. A 42-year-old woman with hypertension and dyslipidemia underwent a 1-day rest stress exercise myocardial perfusion SPECT with technetium 99 imaging to evaluate symptoms of atypical chest pain. Her resting ECG showed LV hypertrophy. She exercised for 12 minutes and 30 seconds on a standard boost protocol and attained a peak heart rate of 155 beats per minute. She developed a brief, sharp parasternal chest pain during the test that resolved quickly during recovery. Based on the images in figure 1.1, which of the following statements is correct? So Eugene, can you scroll down to the figures? Eugene, can you scroll down to the image? Okay, thank you. So this is a picture showing the myocardial perfusion imaging. So starting from the top left, that is a short axis view. The very first image in the top left corner, both stress and rest. Those are short axis views. And so for short axis views, yes, exactly, one Eugene has circled. So if you divide this circle, the upper part would be anterior, the bottom part will be inferior, the left side lateral, the right side septal. Yes, thank you. Sorry, the left side septal, the right side lateral. Now you realize that when you look at the anterior part, that part is dark purple, whereas the rest of it looks orangish, reddish, kind of. And you realize that the way the coloring is for both the stress and the rest is the same. Now this shows the myocardial uptake of the radioisotope, that's the technetium-99. So the areas where the uptake was good is brightly colored, and then where the uptake was poor is the purple part. Now when you come down to the next image, that's the next set of 4 images. So again, stress and rest. The one on so in this case, the left wall is the septal wall, the right wall is the lateral wall, and then you have the apex over there. Again, you realize that for both stress and rest, it's the same thing. At the apical area, you have the poor radio isotope uptake, whereas for the rest of it, you have good uptake. Then you come to the last set of 4 pictures. So with this one, on the last set of 4, when you draw a line to bisect it, the upper part is anterior and the lower part is inferior. And then on the far right, you have the apex. And again, you can see that the anterior toward the apical part is shows a poor radiotracer uptake, whereas the inferior wall has a good uptake. Now, in reading a nuclear myocardial image, you need to ask yourself whether there's a defect, and if there is it fixed or reversible? A fixed defect means that in stress and at rest, the defect is present. A reversible one means that in stress it is present, but at rest it is absent. That means that that defect has reversed. Looking at this, all the stress images and rest images have the same defect, so this would qualify as a fixed defect. Now, they also add diastolic and systolic frames. And just like we would do when you're doing an echo, change in the diameter of the cavity, which is indicative of wall motion. So when you look at the diastolic frames and look at the corresponding systolic frames, you realize that the LV cavity in the diastolic frames are generally wider or larger than that in the systolic frames. And you can see that in the systolic frames, the wall in all the LV walls and all the images look thicker, which suggests that they've contracted quite well. Okay, so now can we go to the questions? Eugene, can you scroll up, please?
Okay, don't you see it? Hello?
Yes, now I see it. Okay. Yes, I see it now. So the first question, the SPECT myocardial perfusion images are diagnostic of a transmural myocardial scar in the distribution of the mid-LAD territory. Now we will flag this answer because from the images we saw that there were fixed perfusion defects in the anterior toward the apical walls. So this answer could be correct, so we'll flag it. B says the anterior wall defect is likely an artifact due to breast tissue attenuation. Now, again, we are seeing anterior wall defects here, and breast attenuation just means that because of the presence of the breast, it may obscure the image such that it would look as if there is a defect. And so, given the kind of images that we saw, would also flag B, and then we'll discuss later. It would have been a better choice of radio tracer in this patient. Thallium wouldn't be a better choice because thallium, first of all, has a lower energy than technetium. So thallium will have a higher chance of giving perfusion defects. Secondly, thallium has a much longer half-life than the technetium. So given that the question said it was a one-day rest stress protocol, it would be difficult to do that with thallium. The gated SPECT imaging cannot differentiate attenuation artifacts from a true perfusion defect. That is false. And when we discuss A and B, we'll understand that. And then E, a transmural scar is associated with reduced wall motion but normal thickening on gated SPECT imaging. Again, if there's this would come out as we discuss the A and B. So we agree that there's a fixed defect, but you realize that in systole there was adequate thickening as compared to diastole, which suggests that there is actually adequate wall motion. Now, if you have a transmural scar, which means that myocardial tissue has been replaced by fibrotic tissue, then you lose that contractile ability. So then you wouldn't have the muscle at that side contracting appropriately during systole. And so because we saw this adequate contraction, that would suggest that A would not be true, because though it has the likeness of a transmural scar, there was adequate contraction in systole. E is also not true because there is normal wall motion. So that makes B the most likely answer, that the defect was due to breath attenuation, but because we know it is attenuation because in systole there was adequate wall thickening. And so that's it for this one. So this one, the answer is B. Okay, Eugene, can we go to number 12, please?
Hello.
Just hold on a bit. If we can have further questions, it seems this place is a little bit technical, and then maybe we'll call on Prof to give any input he may want to add to it. Somebody wants to ask a question. Dr. Adejiji Odebayo, over to you.
Yes, please, I would like you to go over the picture again, the explanation.
Okay. Eugene, can you go to the picture again, please? So the idea of the nuclear myocardial perfusion imaging is that when a patient exercises in a normal vasculature, there is dilatation of the coronary bed, which is mediated by beta-2 adrenoreceptors, so that there's increased myocardial perfusion during exercise. Now, when the patient reaches peak exercise, or if it's pharmacological, when you give the vasodilator, then you would inject the radioisotope. It's expected that the radioisotope would bind to, or the healthy myocardium would take up the radioisotope and will become bright on the camera. Areas that have undergone fibrosis, for which reason there is poor myocardial viability, taking up the radioisotope. Now, because of the fat tissue in breast, this can obscure the image taken such that even where radioisotope uptake may be adequate, it would appear dark as though there is a defect. So this is the basis of it. Now, another thing is, if you take images in diastole and systole, and then you note how well the left ventricular muscle thickens in systole, then that adds diagnostic value. So if you see a defect, or what you think is a defect, but you realize that in systole compared to diastole, the muscle, the left ventricular myocardium thickened appropriately, then that tells you that even though it looks like a defect, since it has contracted appropriately, it is an artifact or it is an attenuation. It is not an actual defect. Whereas if you had an actual MI, where the myocardium has been replaced by fibrous tissue, then in systole, you would realize that that part will not contract, similar to what you will see when you're doing an echocardiogram. Okay, so Eugene, can you please go back to the picture?
Thank you.
Okay, so you don't need me to go back to.
No, go ahead. Explain the picture again.
Okay, so Eugene, the picture, please. Yes, so when you look at the far left, you realize that the pictures are in groups of 4. So on the top left corner, the 4 over there are the short axis view. Similar to the short axis view on an echo, the upper part is anterior wall, left side is septal wall, right side lateral wall, bottom side inferior wall. Now, when you look at the first set, that's the short axis, you can see that in the anterior wall, the radioisotope uptake was poor. So that part is a dark purple, whereas the rest of the myocardium is lit up because it has taken the radioisotope. When you look at the next set of 4, in this view, the left is the septal wall, the right is the lateral wall, and then you can see the apex in the middle at the top. When you look at it, you realize that the septal wall is bright, lateral wall is bright, but the apical area shows poor uptake. And you see that in both the stress and the rest images. If you see it in stress and rest, it is called a fixed defect because it is not changing. If you see it in stress, but when you come to the rest image, everything is nice and bright, then it means that it's a reversible defect. And so that would suggest that there is some viability over there. Now, when it comes to the last set of 4, so the last set of 4, you see the apex on the right side, and then yes, where the cursor is, that is the anterior wall, and then down is the inferior wall. So here too, in the stress and rest images, you can see that in the anterior towards the apical wall, there is poor uptake of the radioisotope, and this is present in stress and rest images. So all these images show a fixed anterior wall defect. All right. Now, when you look at the diastolic frame, okay, so that is in the second column. So end diastolic frame, you just look at how the walls and the left ventricular cavity within the walls looks. Then you come and compare it to what is on the right. You realize that the LV cavity has become smaller, which suggests good contraction. You realize that the muscle wall has all thickened well. And in fact, even over here, when you look at it, you can see that the defects that you were seeing on the other images are not so pronounced over here. So this tells you that even though you had a fixed defect, the adequate wall thickening with narrowing of the ventricular cavity suggests good wall motion, which you will not get if you actually have an ischemic heart disease with a transmural infarct. So then with this, it tells you that what you have is actually an attenuation. And in this patient, it's the breast that was causing the attenuation. And I think the diaphragm also causes some attenuation of the image. But in this case, given the scenario we have, it's caused by the breast attenuation. And that's what makes B the correct answer. If we did not have this systolic and diastolic frame showing appropriate wall motion, then we would have just had a fixed defect. And then we could have considered A as an answer, that is transmural defects involving the anterior wall. But since we have these images that show adequate contraction, then it tells us that it was just an artifact, or it was just an attenuation. Thank you. And any other comments or?
In the absence of any other comment, you can go ahead. Thank you. Oh, Prof, do you have anything
Yes.
to answer?
Yes. So thank you, Jerry, Chief, for this presentation. And the previous question, actually tried to raise my hand to emphasize the fact that one of the indications for a stress ECG is some advanced form of aortic stenosis, especially when you have stage C. We know that they classify aortic stenosis from A to D, right? So in the stage C, you have asymptomatic severe AS, and in order to determine if this patient should go for surgery, one of the things you do for them is actually to do a stress ECG. Because when you say stage C, it's asymptomatic severe AS. But patients that go for surgery are those that are actually symptomatic. So in order to induce the symptom is when you tell them to go for a stress ECG or a stress test. It's part of the test that is done in AS, aortic stenosis. So just wanted to pull up that point. It's in Braunwald. Just check the classification from the stage A to D. You will see in the last column, they put it there. Stress test in order to induce symptom. Hope I'm audible enough. So am I audible, sir?
Yes, you
Yes,
are.
Prof.
You are audible.
For SPECT and nuclear imaging, so it's important to note that we all know there's SPECT. So one of the advancement of PET over SPECT is the ability to nullify any false positives. So one of the things that can cause false positive in a SPECT test is that attenuation artifacts. So they can have attenuation artifact from either a breast, from the lungs, because of consumption of the radionuclear materials, and as I said, from the diaphragm. So that's why there's more shift to doing a PET than a SPECT. But we all know PET is more expensive. Getting the radio isotope is more tedious than the SPECT. So it nullifies all those artifact effects. Now, so one beautiful thing to remember about doing a nuclear imaging is to see nuclear imaging as if you are doing an advanced form of stress test. So the same way we're going to do a stress echo, stress ECG in patient that has ischemic heart disease. You want to induce the ischemia. So if you are doing nuclear imaging, you are trying to induce the ischemia. So we all know the typical feature of ischemia. The pain will come up with stress, right? And resolve with rest. So it means that at that time of stress, there is impairment in myocardial perfusion, right? And so they need a rest at that time so as to improve myocardial perfusion. So if you do a nuclear imaging, at that time, the stress is trying to induce ischemia. So the agent which you use, adenosine, regadenosin, for the stress aspect of the nuclear imaging, you're using those agents to induce the stress. Now, when you induce the stress, you would expect that there should be, if the patient has ischemic heart disease, there should be reduced perfusion, right? So that means coronary that is in ischemia will have reduced perfusion, right? So that simply means that you now see reduced uptake in that coronary territory. At rest, if that myocardium is still viable, then it should be able to take up, right, the radioisotope, right, and there will now be improved perfusion at rest. So that's what I guess it's Dr. Eugene, right?
Dr. Samoa.
Dr. Samoa. It's nice to hear your voice again.
Samoa.
A long time.
Yes, Prof. Nice to hear you too.
Yeah, great. So So what we're trying to emphasize here is that at stress, there's reduced perfusion. So uptake will be reduced. At rest, which we expect for normal ischemia and rest to reduce the ischemia, perfusion should improve. So that you have induced ischemia with that. If you see perfusion defects at stress and improved perfusion at rest, depending on the coronary territory. However, if there is impaired perfusion at stress and there is still persistent impairment of that same perfusion at rest, it simply means that the myocardium in that axis, even if you improve coronary blood flow to them at rest, they are not taking the radioisotope. So that means they are dead tissues. So that is an infarcted area, as in they are not viable. So you need the myocardium to uptake this radioisotope so as to, that's what you now see as the fluorescing on the imaging that you see in the nuclear stress test. So if it's a fully infarcted, non-reversible infarct, then there will be impaired perfusion both at stress and at rest. Hope that is clear. Number two aspect you should now know is that if there is reduced perfusion at stress and there is improved perfusion at rest, that means that those tissues are still viable. They can take up radioisotope. So that means that if you revascularize those tissues, the patient can have a better outcome. Unlike the previous patients, if you revascularize them, there will be no improved outcome because they are dead compared to the reversible ischemia. Is this clear?
It's clear, sir. If it's not clear, you can unmute to ask at any point in time. Thank you. It's clear,
okay.
sir.
Now, so the other set of images that was shown on the right hand side, where we saw the cardiac cavity, as he rightly explained, are diastole and systole. So this one important thing we should note here is that when we're actually doing PET scan, stress and PET scan, you want to focus basically on the diameter of the cavity. So this is the catch. In diastole, we know that the diameters are dilated, right? Now, in systole, in the systolic frame, if the cavities are still dilated, then that tells you that there's problem with contractility. This is really ischemic disease. Because if the muscles are well contracting, the cavity should reduce. So one thing, first important thing we focus on here is diameter, or the diameter of the cavity. Number two important thing here is that you can also use this to see the myocardial perfusion, both in diastole and in systole, which is clearly, as clearly explained. The last important thing is that for PET CT, it can actually quantify the volume of blood flow through the coronary artery. So we talk about coronary blood flow. So it can tell us, it can quantify it for us to tell us that, oh, there's reduced perfusion or reduced coronary blood flow or not. That is better achievable with PET than with SPECT. Now, so when I started the discussion, I said one advancement of PET over SPECT is that it helps us nullify the false positive. So false positive, as we clearly stated, are anything that will attenuate the perfusion. So like as I said, breast, lungs, diaphragm, they can all attenuate perfusion. That is seen more in when you're doing a SPECT test. Unlike when you're doing a PET test, that is removed. Any questions at this stage? So as
I think we can go ahead, sir.
Dilated, and the cavity is persistently dilated in systole, then there's really impaired perfusion. Okay, thank you very much.
Thank you very much, bro. So as we've discussed, the answer for this one is B. So question 12. An 82-year-old man with a history of coronary artery disease underwent coronary artery bypass grafting surgery 6 years ago. He presents to the emergency department with the right upper quadrant abdominal pain and anorexia. His medications include aspirin, metoprolol, succinate, and atorvastatin. Physical examination, laboratory assessment, and abdominal ultrasound confirmed the diagnosis of acute cholecystitis. The patient has normal vital signs and his pain is improved with analgesia. The cardiovascular consultation service is called to perform perioperative. Eugene.
Is it in now? I think there's a time lag. I'm already there, but I think it's delayed.
I can see it. But if you can scroll a bit to the 12.
Fifi, check how you have enlarged it on your screen. Maybe that's the problem.
Okay. Yes, thank you. Okay, so to assess a preoperative risk assessment prior to cholecystectomy, the patient lives with his spouse in a 2-floor home. He does not routinely exercise, but is able to walk up 1 flight of stairs to his bedroom each night without chest pain or shortness of breath. He denies current angina or dyspnea on exertion. There has been no orthopnea, paroxysmal nocturnal dyspnea, or peripheral edema. The cardiovascular examination is normal, and his ECG in the emergency room is unchanged from a prior tracing 4 months earlier. What is the next appropriate step? So with this one, okay, so the answer is recommend percutaneous cholecystectomy rather than laparoscopic or open cholecystectomy due to the high risk of surgery. Recommend vasodilator myocardial perfusion imaging prior to surgery. Recommend that he proceed to surgery with no further cardiac testing and stop metoprolol succinate prior to surgery. Okay, so for this patient, he has had a cabbage done in the past, and following the cabbage, he has had no limitations in terms of physical activity. He's able to climb stairs. He doesn't have any angina. He doesn't have dyspnea. He doesn't have any heart failure symptoms. And his ECG is the same as it was 4 months earlier. So in terms of his cardiovascular profile, there hasn't been any decline since his surgery. And since he had the cabbage, the fact that he does not have any angina and any issues with physical activity suggests that the bypass graft is still patent and is perfusing the coronaries. So this would be classified as a low risk surgery, and so A would not be true. This is not high risk, so he doesn't need percutaneous cholecystectomy. A stress myocardial perfusion scan is important for patients who have symptoms. So then anatomical scans are recommended for those who you may suspect have lesions but may not necessarily have symptoms. That's where you would want to do anatomical scans like a CT coronary angiogram. But then for those who have known lesions that you want to determine the functional significance of these lesions or the physiological significance of these lesions, then you'd want to do a physiological test like a stress test. Now, this patient does not have any symptoms that suggest cardiovascular disease. He doesn't have any angina, so he's completely asymptomatic. So for him, there wouldn't be the need to do a vasodilator test. Then option D, there's no indication to stop the metoprolol succinate. And in fact, given his history of ischemic heart disease necessitating the CABG, the metoprolol, which is a beta-1 antagonist, is beneficial in the sense that it's still reducing myocardial workload, reducing the risk of ectopy, etc. So then it wouldn't be ideal to stop the metoprolol prior to surgery. So in this patient, he can proceed with his surgery without further cardiac testing because from a cardiovascular point of view, he's clinically stable. So that makes C the answer. Okay, so question, if there are no other comments, then we'll go to question 13. Can you scroll up a bit so I can see the full question 13? A 56-year-old asymptomatic man with a history of hypertension and cigarette smoking is referred for an exercise treadmill test. After 7 minutes on the standard Bruce protocol, he is noted to have, Eugene, you've gone too far. Thank you. He's noted to have 1 millimeter of flat ST segment depression in lead 2, 3, and AVF. He stopped exercising at 9 minutes because of leg fatigue and breathlessness. The peak heart rate is 85% of the maximum predicted for his age. The ST segments return to baseline by 1 minute into recovery. Which of the following statements is correct? So there's a patient with hypertension, a male who's middle-aged with hypertension and a smoking history. While these would increase his cardiovascular risk, he's asymptomatic at this point. So he went ahead to do the stress ECG. Now, it's important to note that in interpreting ST segment changes, ST depressions are non-specific for vascular territories, or they are non-localizing, whereas ST segment elevations localize lesions to specific vascular territories. So for option A, even though the ST depressions of 1 millimeter, flat meaning horizontal, which qualifies as significant, even though it is in at least 2, 3 AVF, this does not equate to inferior wall or right coronary artery ischemia. So then, for this one, because the ST depressions do not localize to the right coronary artery as ST elevations would have. Can we go to option B? Eugene, can you please scroll so I see option B?
Yeah, Kofi, I think it's with your device. I've been there for like some time now.
Okay, I think there's a lag, but it's come now. His risk of death due to an acute myocardial infarction during the next year is greater than 50%. So when doing a stress ECG, the risk of mortality is predicted using the Duke treadmill score, which factors in the occurrence of chest pain, the time exercised, and the depth of ST segments. We can look it up, but then based on those parameters, his risk of death is definitely less than 50%. So that makes B a false statement. C, he should proceed directly to coronary angiography. So some may argue that because he has the ST segment depressions, which are 1 millimeter horizontal, which qualifies as significant, he should go ahead and then have an angiogram done. However, we need to remember that this is a patient who is asymptomatic. So in a patient who is asymptomatic and also did not have any pain during the exercise, and was able to exercise up to 9 minutes, the prognostic value is, or the overall coronary risk is not high enough to warrant to warrant referring directly to have a coronary angiogram done. Then the next one is the test predicts a 25% risk of cardiac events. Sorry. Sorry, my screen is reloading. Yes, so the test predicts a 25% risk of cardiac events over the next 5 years, most likely the development of angina. And then E is this is likely a false positive test. Given the fact that he has risk factors, even though he's asymptomatic, but then he still has a history of hypertension, smoking, he's a male and he's 56. Even though he has these and he's asymptomatic, it doesn't necessarily connote a false positive test because he does have risk factors. So that would make E also false. And so he still does have a risk of cardiac events. So then he would still need to be managed in that regard. And that would make D the true answer. So 13 will be D. Okay, so question 14. Do FT segment depressions during standard exercise testing increase the diagnostic probability of significant coronary artery disease? As most of us would know, a left bundle branch block is in itself an absolute contraindication to stress testing. Because there's a saying that a left bundle branch block does not lend itself to further interpretation. And patients with left bundle branch block already have downsloping ST segment depressions, and these do not these affect the reliability of a stress ECG. So right from that point, based on that, A is out because you don't do a stress ECG for someone with the left bundle branch block. B, a 45-year-old woman with diabetes and hypertension with LVH on her baseline ECG. LVH can also be tricky in the sense that we know LVH sometimes goes with repolarization abnormalities that give a strain pattern. So you may have ST depressions or T-wave inversions, mostly in the lateral leads, but sometimes in the inferior leads as well. And if these are present, then it would confound your results in terms of the ST depressions that may occur during the test. So in these patients, the prognostic value is the diagnostic probability is not so high. So that would make this also false. Jumping C, I'm going to be a 28-year-old woman with pleuritic chest pain after gymnastics class. So again, 28-year-old female, pleuritic chest pain. This does not sound like cardiac chest pain. So this patient already has a low diagnostic probability. And so here ST depressions are likely to be a false positive. So D is false. E, 63-year-old man exertional dosing on a beta blocker, digoxin and nitrate therapies. So again, digoxin as one of its effects on the ECG can cause ST segment depressions, frequently referred to as the Salvador Dali sign, named after the mustache of one Salvador Dali. So if the patient is on digoxin and undergoing the exercise, those ST depressions may be as a result of the digoxin. So again, it is recommended that if you're going to the stress ECG, digoxin should be one of the medications that are stopped. So E is false. So that brings us to the 76-year-old woman with new exertional dyspnea, a history of cigarette smoking, and a normal baseline ECG. This patient with a history of smoking, her age, and the fact that she's postmenopausal increase her cardiovascular risk. She has a new onset exertional dyspnea, and that's is suspicious of potential ischemia given her age and risk factors. And she has a normal baseline ECG, which means that whatever changes you get during the test can appropriately be interpreted. So this would give the highest diagnostic probability. So number 14, C is the answer. Okay, so the last one, number 15. Okay, so number 15, which of the following statements regarding cardiac catheterization is true? A, risk of major complications is 2 to 2.5%. The risk is actually less than 1%, so A is not true. B, okay, Eugene. Okay, let me try and read it from here. So B, the incidence of contrast-induced nephrotoxicity in patients with renal dysfunction is decreased with intravenous administration of mannitol before and after the procedure. Mannitol is an osmotic diuretic, so if you are to administer mannitol, it would cause increased tonicity or increased osmolality of the intravascular space. And so this will cause cellular dehydration, cause diuresis, and overall cause volume contraction. And volume contraction or dehydration contributes to contrast-induced nephrotoxicity. So rather, giving mannitol will worsen or will increase the chances of contrast-induced nephrotoxicity. So B is false. C, high osmolar non-ionic contrast agents demonstrate reduced incidence of adverse hemodynamic reactions compared to low osmolar ionic contrast agents. So C is also false, and also actually increase risk of contrast nephropathy. And if they are high osmolar, then they would tend to draw fluid into the intravascular space and then cause hemodynamic issues. The 1 French unit is equivalent to 0.33 millimeters. That one is true. There's no explanation to it. It is true. And then E, retrograde left-sided heart catheterization is generally safe in patients with tilting disc prosthetic aortic valves. That is false. Catheterizing these patients can end up damaging the valve. The catheter may damage the valve. And so you wouldn't want to do it in these patients. So D is the answer. Okay, so thank you very much. And I'm done with my questions.
Yeah, thank you, Kofi. So we go to question 16.
Good evening, everybody. My session is question 16 to 20. Can I go ahead, please?
Please go ahead.
Thank you. A 75-year-old woman was brought urgently to the cardiac catheterization laboratory in the setting of an acute ST elevation myocardial infarction. She had presented with chest pain, epigastric discomfort, and nausea. Physical examination was pertinent for diaphoresis, heart rates of 52 beats per minute, blood pressure of 85-50 millimeter of mercury, jugular venous distension, and slight bilateral pulmonary rheos. Coronary angiography demonstrated ostial occlusion of the dominant right coronary artery without significant left-sided coronary artery disease. Which of the following statements is correct? So just looking at the question and picking out the salient points, she's a 75-year-old woman. who has an ST segment myocardial infarction. On physical examination, there was evidence of bradycardia of 52, blood pressure was reduced, there was hypotension of 85/50 millimeters of mercury, JVP was elevated, and coronary angio showed that there was a right coronary artery occlusion. So which of the following statements is correct? Question number, option A said there is isolated infarction of the right ventricle without left ventricular involvement is likely. Option A is false. And the reason why option A is false is that the question said that there is right coronary artery infarction, and the right coronary artery actually supplies some part of the left ventricle. The right coronary artery supplies the left ventricular inferior wall and also supplies the left ventricular posterior wall. So the option A that says that only the right ventricle will have an infarction without left ventricular involvement is false, because there will be left ventricular inferior wall infarction and posterior wall infarction. Option B says that ST segment elevation in leads V1 and V2 will be expected to accompany the inferior ST elevation. Option B, like I said, the right coronary artery actually supplies the left ventricular posterior wall. And in a myocardial infarction, to see the posterior wall can actually be seen by placement of leads V7, V9 in the posterior regions of the chest. And the posterior wall infarction will show ST elevation in leads V7 to V9 and would show a reciprocal change in leads V1 and V2. So in an ECG where we don't regularly put on the V7 to V9 leads, when you look at lead V1, V2, you see an opposite of what you would see if there was lead V7 to V9. So in leads V1 and V2, to show that there is posterior wall infarction, ST depression is noted in lead V1 and V2, but the option B said there will be ST elevation in leads V1 and V2, and that is false. Option C says that the abnormal heart rate and blood pressure are likely a consequence of vagal stimulation. It's important to note that when there is right ventricular infarction, when there is a right coronary artery, when there is RCA infarction, and there is often affectation of the inferior wall, it actually causes sinus bradycardia is common, and also hypotension is common. And this is often from stimulation of vagal afferent nerves that are seen mostly in the inferior posterior wall of the left ventricle. So that's why it's important in myocardial infarction, if there is a need to even give morphine in myocardial infarction in inferior wall, you should be watchful of possible hypotension that could occur. So other things that could cause bradycardia and hypotension in myocardial infarction when there is right coronary artery involvement, it could also come from the fact that the right coronary artery supplies the SA node. It gives off a branch to the SA node, and this can cause sinus bradycardia. Also, there is also, in some cases, it also gives rise to the blood supply to the AV node in 85% of the time. So for option C, the abnormal heart rate and blood pressure are likely a consequence of vagal stimulation. That is true. Option D, there will be ST segment depression. ST segment depression is expected in lead V4R. Lead V4R will actually show us that there's right ventricular infarction. And in right ventricular infarction, if you place the lead V4R, you should see an ST segment elevation and not an ST segment depression. So the answer for question 16 is C, that the abnormal heart rate and blood pressure are likely a consequence of vagal stimulation. That is true. I don't know if there's any contributions or questions before I move to the next question. Okay, question 17. Using Doppler echocardiography, the following values are obtained in a patient with a restrictive ventricular septal defect and mitral regurgitation. Systolic transmitral flow velocity was 5.8 meters per second, and systolic flow velocity at the site of the VSD is 5.1 meters per second. The patient's blood pressure is 144/78 millimeter of mercury. The question is, what is the estimated right ventricular systolic pressure? Important thing to note here is that the question says that this patient has a restrictive ventricular septal defect. By restrictive ventricular septal defect, it's like it explains that there is actually it's not a large VSD, it's actually a small VSD. And there is increased pressure. The pressure on the left is more than the pressure on the right. So there's like a flow, there's a left-right shunt in this form of restrictive ventricular septal defect. There's also a mitral regurgitation. And so what we know here is that there's a VSD, and we're also giving values for the systolic flow velocity of the VSD and the patient's blood pressure. Formula to calculate a right ventricular systolic pressure in this setting is actually still using the Bernoulli's equation. You're going to be able, that's using 4V max squared. It tells you the pressure gradient against an orifice. So the pressure gradient that is across this VSD can actually be calculated by using 4V max squared. And that will give us the pressure in the left the pressure across the VSD. It's important to note that for us to know what is the left ventricular systolic pressure, the left ventricular systolic pressure here is going to be the same thing as the systolic blood pressure of the patient, as long as there is no obstruction in the aorta. So if there is no obstruction in the outflow tract of the left ventricle, it tells us that the left ventricular systolic pressure is going to be exactly the same as the systolic blood pressure. So finding the right ventricular systolic pressure here, the formula will be the right ventricular systolic pressure will be equals to the systolic blood pressure, which is the same thing as the left ventricular systolic pressure, minus the pressure gradients, calculating with the Bernoulli's equation, 4V max squared, to find out the pressure across the VSD. So that is RVSP will be systolic blood pressure minus the pressure gradient across the VSD. So doing that calculation, we have systolic blood pressure here is 144 minus 4V max squared. 4V max, V was 5.1. 5.1 squared is, sorry, please, I did not times it. Let me just multiply it. 5.1 times 5.1. 6 times. Sorry, please. My calculator is misbehaving.
It's 104.
Okay, thank you. 104. So we now do 144 minus 104. And the answer we get is
40
millimeter of mercury. So the answer is 17 is C. Is there any clarifications or questions? Okay, question 18. A 68-year-old woman with a history of diabetes, cigarette smoking, and previously normal cardiac examination is admitted to the hospital with the new onset of exertional dyspnea and orthopnea. She describes having experienced a muscle ache in her anterior chest 10 days earlier, that lasted several hours and has not recurred. Her blood pressure is 109/88 millimeter of mercury. The heart rate is 102 beats per minute, and she is afebrile. Her examination reveals an elevated jugular venous pressure, bibasal crackles, and a 1+ pitting edema of both ankles. On auscultation, there is a grade 2 early systolic murmur between the left sternal border and the apex. The ECG reveals the sinus tachycardia with an inferior Q wave, and they were not present on a trace in 6 months earlier. The chest X-ray is consistent with pulmonary edema. She's admitted to the hospital, and the transthoracic echo is obtained that is technically limited due to her body habitus. It reveals a left ventricular ejection fraction of 60% with inferior wall hypokinesis. The mitral valve is not well visualized, but appears thickened, and there's an anterior directed jet of mitral regurgitation that is difficult to quantify. A diuretic is administered. Which of the following is the most reasonable approach in her management? Just a brief recap of the question we read. She's 68, diabetic, takes cigarettes, and has new onset dyspnea and autopnea. She had an anterior chest wall pain about 10 days earlier. Her blood pressure and pulse rates are as recorded. ECG shows that there's sinus tachycardia and an inferior Q wave, and there is a new murmur head, and an echo shows that there is normal EF, but has inferior wall hypokinesis. And the mitral valve, there's a mitral regurgitation, but the mitral valve was not well visualized. So this is telling from the history so far, the patient obviously had an myocardial infarction with an inferior wall hypokinesis that is showing. And this was 10 days earlier. So it's not a recent myocardial infarction. It was not recent. It's not like within the past 4 hours for us to put on emergency therapy for her. So which of the following is the most reasonable approach in her management? Question A, option A says an urgent coronary angio with planned percutaneous coronary intervention. Option A is not going to be correct because this says urgent coronary angio. This happened 10 days earlier, and it's not there's already Q waves developed, so there is no need for an urgent coronary angio at this time. Option B says a nuclear stress testing to evaluate for ongoing ischemia. I think a nuclear stress testing will not address the urgent problem the patient has now. Patient actually has a myocardial infarction, actually has a mitral regurgitation that is ongoing and has inferior wall hypokinesis. So I don't think a nuclear stress test is the best option now. Option C says a transesophageal echo and surgical consultation. Option C, for the transesophageal echo, the patient during the transthoracic echo, there was mitral regurgitation. It was not well visualized. So I think a transthoracic echo would visualize the valve properly, and possibly there's been a development of complication from the myocardial infarction. You could have papillary muscle not supplied and has caused valvular problems, and there is a regurgitation. So option C, yes, transesophageal echo should be done and surgical consultation should be done to help repair if there is an acute myocardial regurgitation, acute mitral regurgitation occurring. Option D says initiate long-term management with aspirin, angiotensin converting enzyme inhibitor, and a beta blocker therapy. Option D is wrong because the patient has an obvious complication from the MI the patient has, and just initiating long-term management is not correct. Urgent right catheterization to evaluate for a left to right shunt. Left to right shunt possibly will occur if there was development of maybe a VSD if there was a development of a ventricular septal defect as a complication of the myocardial infarction. An urgent right heart catheterization will be adequate. But from this history that we have, there is nothing pointing towards that. The murmur that is heard is a murmur of an acute MR. So I think the right answer here is C, a transesophageal echocardiography and surgical consultation. Any questions or contributions, please?
Sorry, please, just to add something. So you see in the question, it said that the mitral regurgitation was an anteriorly directed jet. And I think it gives a clue, as in, rather than it being a central jet, which is what you would typically expect if you just have, let's say, a degenerative mitral regurgitation or something. The fact that it's anteriorly directed suggests that there is a prolapse of the posterior leaflet, for which reason the jet is directed anteriorly, and that gives a clue that in addition to the fact that there's an inferior MI, gives a clue that there is a rupture of the papillary muscles. But also, if it's just a general question on a mitral valve prolapse, and it's the posterior valve leaflet that is prolapsed, then it would also give an anteriorly directed jet. In which case, when you auscultate, then the memma of the regurgitation will not radiate to the axilla, but will rather radiate anteriorly toward the stem because of the direction of the jet. Thank you.
Thank you very much.
And
Question.
like you rightly stated, I think this question was also crafted to look at possible complications of MI when you do not intervene. So you look at the E, and the E seems to be assessing the possibility of ventricular wall rupture post-MI, which can lead to a left to right shunt. So I think it was drawing our attention to us, maybe we should always think about possible complications of MI, especially the ones that we do not intervene, leads to risks of mechanical complications.
Okay, thank you very much. Question 19. Which of the following statements regarding altered electrolytes and electrocardiographic abnormalities is true? Hypokalemia causes peaked T waves. Hyperkalemia causes QRS narrowing and increased P wave amplitude. So this is actually listing different electrolyte abnormalities. So going to the questions, question option A says that hypokalemia causes peaked T waves. That is not true. What causes peak T waves in potassium is actually hyperkalemia. Hyperkalemia will naturally cause stall-tented P waves, like we know how it progresses. We call stall-tented P waves prolonged PR interval, flattened or absent P wave. So for hypokalemia is actually the opposite of it. Hypokalemia causes flattened or inversion of T wave, causes QT interval prolongation, and also visible mild ST depression in very severe cases. So option A is false. Hypokalemia does not cause peaked T waves. It rather causes flattened or inversion of T waves. Option B says hyperkalemia causes QRS narrowing and increased P wave amplitude. No. Hyperkalemia will cause a widened QRS and will cause absent or flattened P wave. Option C says hypomagnesemia is associated with monomorphic ventricular tachycardia. For hypomagnesemia, it's important to note that most times you actually have hypomagnesemia occurring with hypokalemia and hypocalcemia. So the ECG pictures of these conditions can also be seen in hypomagnesemia. But important thing to note for hypomagnesemia is that they have prolonged PR interval and they also have prolonged QT interval. And when there is a predisposition to ventricular tachycardias, and they do not have monomorphic VT, rather they have polymorphic VT. So they have prolongation of QT interval that could lead to torsade de pointes and polymorphic ventricular tachycardia. Option D says hypocalcemia causes prolongation of the QT interval. No. Hypocalcemia actually will shorten phase 2 of action potential because there is less calcium. So it will cause prolongation of QT interval instead. So sorry, hypocalcemia, yes, will cause prolongation of QT interval because it shortens phase 2 of the action potential. Option E, severe hypocalcemia has been associated with the presence of J wave. Presence of J wave is actually seen as the Osborn wave. You see J waves presence in hypercalcemia, and not in hypocalcemia, and it can actually be also seen in hypothermia. So option 19, which of these ECG abnormalities is true? The answer is D. Hypocalcemia causes prolongation of the QT interval. Questions, contributions, please. Question 20. A 46-year-old woman with progressive exertional dyspnea was recently found to have bilateral hilar adenopathy on chest X-ray and first-degree AV block on her ECG. A transbronchial biopsy demonstrated non-cassating granulomas consistent with sarcoidosis, and she is referred to you for assessment of cardiac involvement. Which of the following statements is true regarding the diagnostic evaluation of cardiac sarcoidosis? Sarcoidosis is actually a multisystem disorder of unknown cause, and it's actually noted that it's usually, most times, it's clinically, as you could have clinically isolated cardiac sarcoidosis. That is where sarcoidosis is just occurring only in the cardiac muscles. But most times it's present with extracardiac features, and the commonest is actually in the lungs. Left ventricular, okay, the options. Left ventricular regional wall motion abnormalities in sarcoidosis are typically present in coronary distributions. Option A is false. There's actually left ventricular regional wall motion abnormalities, but when it is present, it doesn't follow coronary distribution. It actually it doesn't have any pattern. It has non-coronary pattern. Option B says an elevated serum angiotensin converting enzyme level has low sensitivity but high specificity for the disease. For sarcoidosis, you have elevation of serum ACE. It actually is actually helpful to help make a diagnosis of sarcoidosis. But it's important to note that most times, in a wide range, even in a wide range of patients, they have normal ACE levels despite having untreated sarcoidosis. So ACE can be elevated in about 60% of patients. And this ACE, because it can be present sometimes, it could be normal even in people who have confirmed sarcoidosis. This test has both low sensitivity and also has low specificity for identifying this condition. So option B is false. An elevated serum ACE level has low sensitivity but high specificity is false. It has both low sensitivity and specificity. Option C, sarcoid-associated late gadolinium enhancement on cardiac MRI imaging is usually localized to the endocardial border. It's actually noted that cardiac MRI imaging with late gadolinium enhancement is sensitive for identifying abnormalities in sarcoidosis. And he said that it's usually patchy, non-transmural, and spares the endocardial borders. So here it says it's usually localized to the endocardial border. It actually spares the endocardial border and not localized to it. Option D says F-fluorodeoxyglucose uptake on cardiac position emission tomography differentiates active sarcoidosis from inactive scar tissue. Option D is correct. It's noted that FDG position emission tomography PET, that's the PET, it reviews region of inflammation in active disease and actually shows fibrosis when it's an inactive scar tissue. So option D is true. I don't know how to explain them very well, but this was what I saw when I went to do the search. Thank you very much. This is the last question for me. Thank you.
Yeah, thank you very much. So currently we have done the 20 questions, but we still have time, so we want to continue. So I want to humbly ask the one doing 21, if you are ready, and you can continue. We want you to continue. If the person is not ready and anyone after question 20 is ready, we want to make use of the time because remember we are behind time, and next week we'll be doing the presentations, curriculum, in addition to the MCQ. So we might not cover much. So if you are after 20, but you have done your questions and you are ready to take it, please take it for us. I know we mentioned at least 20.
Okay. Hello. Good evening, everyone. Thank you, Dr. Eugene. I'm supposed to take 21 to 25.
Excellent.
Yes. I think I'm ready with the questions. Just number 24. I haven't read much about it, and I'll probably take it in the next class, or if anyone can explain it better. Okay.
No problem. We are grateful.
Okay. So, question 21. It says, which of the following statement about ECG depicted in figure 1.2 is correct? So we'll just go to the ECG in figure 1.2. And we can see this is an ECG showing atrial fibrillation. And you can see an abnormal QRS complex, which is very obvious amongst the normal QRS complexes. And if you can count from the first QRS complex, it's 1, 2, 3, 4 is the fifth QRS complex. So looking at the RR intervals, this is a typical Ashman phenomenon. So Ashman phenomenon means that, or Ashman beat or Ashman aberrancy, it can be called any of these names. It's a phenomenon seen in atrial fibrillation, and sometimes it may be seen in other supraventricular arrhythmias. It's a situation where you find a long RR interval followed by a short RR interval, and then which is terminated by an aberrant QRS complex. Exactly, thank you for that. And it shows an RBBB pattern. So this is Ashman phenomena. So if you can count you see the RR interval, the first, exactly that one is long, followed by a short one. 1, 2, 3, 4, 5. Followed by a short RR interval, and then terminated by an aberrant conduction. That is Ashman phenomenon. It has no clinical significance. And so we can look at the options. It's just a definition of Ashman phenomenon here. The basic rhythm strip is wandering atrial pacemaker, that's false. The fifth QRS complex on the tracing is likely premature ventricular beat. It looks like a premature ventricular beat, but because it has followed the pattern of the long RR interval followed by a short RR interval, then it makes it the Ashman phenomenon. C, the Ashman phenomenon is present and it occurs because the refractory period is directly related to the length of the preceding RR interval, which is true. So what happens, the mechanism of the Ashman phenomenon is that hold on, just a bit. I'm trying to find, I drew something. Sorry, I can't find it. Anyway. So normally, the refractory period is supposed to be directly proportional to the preceding RR interval. So if you find a prolonged RR interval, and then the next one is a short RR interval, so the next conduction, that's the QRS complex, will appear as abnormal. So that is the abnormal QRS complex that shows the RBB pattern. I don't know if you understand that, but that's what the Ashman phenomenon means. Then D, the bundle of His is likely the anatomic location of the conduction delay in the fifth beat because it has the longest refractory period of the conduction tissue. This is false. It's not at the bundle of His. We can even see that the abnormal conduction is showing the RBBB pattern. So even though that the bundle of His has the longest conduction delay, but the block is not at the bundle of His. Normally, the right bundle branch has the refractory periods in the conduction system are followed by from the right bundle branch, which is the fastest, followed by the left bundle branch, then the AV node, and then finally the bundle of His. So if there is any contribution, the answer is C, a Schumann phenomenon. Then the question number 22. The timing of an innocent murmur is usually A, early systolic, B, pre-systolic, C, mid-systolic, D, holosystolic, and E, early diastolic. So what an innocent murmur is otherwise known as a normal flow murmur. It's seen in certain situations or certain circumstances. And there are some types of innocent murmurs. For example, the still murmur, which is seen in adolescents in the left lower sternal area, or then there is another one, there's the pulmonary flow murmur. Then we have the systemic flow murmur, which is heard at the supraclavicular, as a supraclavicular brew. And then we have the venous hump, which could also be heard. These are all types of innocent murmurs. What is peculiar for innocent murmur is they are loudest in mid-systole. So the answer is C here. Any contribution or question? So number 23, which of the following statements about jugular venous waveform is correct? So I think maybe we should revise the jugular venous waveform to understand the options better. So as we know, the jugular venous waveform, it strictly talks about the right atrial pressure, or the pressure on the right side of the heart. So we have, it has 3 peaks and 2 troughs. We have the A wave, the C wave, and the V wave. Then we have the X descent, there is the first X descent, and then there's the X prime, which is the second part of the X descent, followed by the Y, and then the other descent is the Y descent. The A wave, it depicts atrial contraction. So initially, the right atrium, when it contracts, there is an increase in pressure, which is reflected in the internal jugular vein. So that is reflected as the A wave. Then followed by the X descent. The X descent is atrial relaxation and drop in pressure of the right atrium. After the X descent, then we have the C wave. The C wave is bulging of the tricuspid valve with ventricular contraction. So when the right ventricle contracts, the tricuspid valve, which is closed, it bulges inward into the right atrium, so causing an increase in pressure in the right atrium, which is also reflected in the internal jugular vein. So this shows the C wave. Then we have the X prime, which is the second part of the X descent. So here there is with ventricular contraction, there is downward movement of the tricuspid valve. So at this point, it's allowing for atrial filling. That is what is about to happen next. So this is the X prime. Then we have the V wave. The V wave is as a result of passive atrial filling. So at this point, as the atrium is filling the right atrium, tricuspid valve is still closed. So this happens during ventricular systole. Then we have the Y descent. The Y descent occurs when there is atrial emptying with opening of the tricuspid valve. So atrial emptying into the right ventricle. It should be noted that both the X and Y descent, they produce large excursions. So when examining the patient, that is the wave that you usually perceive. And they are the waves that are being seen, the X and Y descent, because they are more exaggerated. So, and also the A wave and the V wave, the A wave is seen with respect to first and second heart sound. The A wave is seen before S1, and then the V wave is seen immediately after S1. So that's another thing that we should note. So let's go to the options. Option A, Kussmaul sign is pathognomic for constrictive pericarditis. Option B, the C wave is a reflection of ventricular diastole and becomes visible in patients with diastolic dysfunction. Option C, the X descent is prominent than the Y descent in cardiac tamponade. And option D, phasic decline in venous pressure, that is the X and Y descent, are typically more prominent to the eye than the positive pressures, that is the A, C, and V waves. And then option E, Canon A waves indicate interventricular conduction delays. So Kussmaul sign is a paradoxical increase in JVP with inspiration. Normally, the JVP is supposed to fall during inspiration because there is increased negative intrathoracic pressure. But in Kussmaul sign, the JVP is elevated, or it rises rather than falling. And this is seen in constrictive pericarditis and tricuspid stenosis, right heart failure, or right ventricular hypertrophy. So option A, yes, it is seen, but it is not pathognomic. Then option B, the C wave is a reflection of ventricular diastole and becomes visible in patients with diastolic dysfunction. The C wave is not a reflection of ventricular diastole, it's rather a reflection of ventricular systole. Because if you remember, we said it occurs with bulging of the tricuspid valve when the ventricle contracts. So that is ventricular systole. Then option C, the X descent is less prominent than the Y descent in cardiac tamponade. This is also false because in the X descent and the X descent, in cardiac tamponade, the Y descent is, X descent is less prominent than the Y descent in cardiac tamponade. So the Y descent it's rapid and deep in constrictive pericarditis, and it is blunted in cardiac tamponade, while the X descent is more prominent. So please, can you move down a bit? So in cardiac tamponade, the X descent is more prominent than the Y descent, rather than it being less prominent. So that's false. Then phasic decline in venous pressure, that's the X and Y descent, are typically more prominent on the eye than the positive pressures. This is true. Like I mentioned earlier, the X and Y descent are more exaggerated, the descent, so they are more appreciated rather than the A wave, the C wave, and the V wave. Then the final option, so the answer is option D. Then the final option E, it says that Canon A waves indicate interventricular conduction delay. Canon A waves are exaggerated A waves, large A waves, and they indicate AV dissociation. And they are seen in, so this is where the right atrium contracts against a closed tricuspid valve. So that is also false. So any contribution?
Thank you very much. So I just want to make a comment on the X and Y descents in constrictive pericarditis and cardiac tamponade. So basically, when you're looking at the Y descent, you should look at it at the likelihood of rushing of blood flow through the tricuspid valve. So anything that causes significant pressure gradient between the right atrium and the right ventricle, such that the right atrial pressure is significantly elevated than the right ventricle, causing a flow, an increased flow across the tricuspid valve when it opens, will give you a very prominent Y descent. Whereas if the pressure gradient between the RA and the RV is relatively narrow, then you won't have a significant wide descent, but it will be blunted. And that's what happens in constrictive pericarditis, where there's markedly elevated atrial pressures relative to the ventricular pressures. So you have a rapid filling of the ventricles or after opening of the tricuspid valve in the early diastole. And that rapid, sharp filling of the ventricle gives you that prominent wide descent in constrictive pericarditis relative to pericardial effusion, where the pressures within the right atrium and the RV literally are equal, and the volume of blood only moves into the RV when there is loss of volume from the RV. So the wide descent literally does not exist or is blunted. So that's what I wanted to add.
Okay, thank you very much. That's much clearer. So if there is no other contribution, we can move to the next question. So like I said, permission to skip 24. I will get back to it tomorrow by the grace of God. I want to understand it properly. So we can go to question 25. Which of the following conditions is associated with the Doppler transmitral inflow pattern shown in figure 1.3? So like we know, the transmitral inflow pattern, is usually where the E wave, that's the first flow, is higher normally than the A wave. The first E wave is passive filling into the ventricle, into the LV, and then the A wave is active filling. So, but in this case, we are seeing that the E wave is shorter than the A wave. So there is reversal of the pattern. So this is usually seen when there is impaired relaxation of the left ventricle. So can we see the options, please? So A is gastrointestinal hemorrhage. Okay, one more thing I wanted to add is this transmitral flow is also volume dependent. So as much as the flow from the left atrium to the left ventricle depends on how much the left ventricle is relaxed, then the more the volume in the left atrium, it also affects this transmitral flow. So option A is gastrointestinal hemorrhage, B is constrictive pericarditis, C is normal aging, D is restrictive cardiomyopathy, and E is hyperthyroidism. So constrictive, so I will take those that are similar. Constrictive pericarditis and restrictive cardiomyopathy, both of them, there is impaired relaxation. And at this point, the most of the feeling is passive in these two conditions, constrictive pericarditis and restrictive cardiomyopathy. Most of the feeling is passive. So the majority of the feeling is at the E wave. So the E wave is disproportionately longer than the A wave. So it will give you a ratio of more than 2. This ratio we are seeing in the image is less than 1. And the normal EA ratio should be between 1 to 2, or as some will say 0.9 to 2. So for constrictive pericarditis and restrictive cardiomyopathy, it will give you a restrictive pattern of the EA ratio. And normal aging, this is usually the pattern that is seen in normal aging, impaired relaxation, where the EA ratio is less than 1, like what we are seeing in this pattern. And is seen in individuals, especially individuals who are older than the age of 70. So the answer is C. For gastrointestinal hemorrhage and hyperthyroidism, I could not really explain it, because what I just saw was that because they are both hyperdynamic states, so at this point there is increased diastolic relaxation of the LV. So this is not the pattern expected. But I don't know if anyone has any other explanation, especially for the gastrointestinal hemorrhage.
Thank you very much.
Please, any contributions?
All right, so please, I just want to ask a question because in as much as this question is showing us diastolic dysfunction, which looks like the age with one, I want to find out from the presenter, can you just throw a little light on the current criteria for diastolic dysfunction? Thank you.
Hello, Dr. Amina.
Sir?
Yeah, please. So there's a question. The person wants you to throw more light on the current recommendations and evaluation of diastolic function, if possible.
Oh, sorry. I didn't know the question was meant for me. Okay. I'd rather revise it and get back to the person. I don't want to give old information, if that's okay, or if anyone has the current criteria.
Okay. All right. Thank you. So the new guidelines, the most updated one I'm aware of is the 2016 by the American Society of Echocardiography and European Association of Cardiovascular Imaging. So essentially, there's categorization into those who have normal left ventricular ejection fraction and those who have reduced left ventricular ejection fraction or evidence of myocardial disease. So for those that have normal ejection fraction, left ventricular ejection fraction, which is defined as greater than or equal to 50%, then the recommendation is to look at 4 parameters. You are looking at the left atrial volume index with a cutoff of 34 ml per meter squared. You are looking at your tricuspid regurgitation with a cutoff of 2.8 meter per second. You are looking at E over E prime, the average greater than 14, and you are looking at the E prime velocity, either the septal or lateral, with a septal less than 7 and with a lateral less than 10. So the patient should have 3 out of 4 of these parameters to fulfill a criteria for left ventricular diastolic dysfunction. If the patient has 2 out of 4, then it is indeterminate. 1 out of 4 or 0 out of 4 essentially is normal diastolic function. That is for those with normal left ventricular ejection fraction. But for those with reduced ejection fraction or evidence of myocardial disease, then already they have diastolic dysfunction. The algorithm now goes to decide whether it is grade 1, grade 2, or grade 3. So essentially, it's dependent on your mitral inflow velocity and also the parameters that have been listed already, except the E prime velocities on their own. So you still require the E over E prime average greater than 14, your tricuspid regurgitation cutoff of 2.8 meter per second, and your left atrial volume index greater than 34 ml per meter squared. Now, if the person has mitral inflow, the mitral inflow of the E over mitral inflow between the ratio between 0.8 greater than between 0.8 to 2. That is where you have to use 3 parameters to decide whether there is grade 2 or not. But if it's less than 0.8, then indirectly the person goes to grade 1. If it's greater than 2, greater than or equal to 2, then it's grade 3. It's those who fall in between. That is where you have to use. So if you have the 3 parameters, 2 out of 3, automatically you have increased filling pressure. So you are grade 2. If you have 1 out of those 3 parameters, then automatically you go to grade 1. If you don't have those parameters, then they cannot categorize your grade. So essentially, the algorithm for the normal EF, the first thing is to establish does the person have diastolic dysfunction. It doesn't talk about the grading based on the 4 parameters. So if you have 3 out of 4, you have diastolic dysfunction. 4 out of 4, diastolic dysfunction. 2 out of 4, indeterminate. 1 out of 4 or 0 out of the 4, normal. Now for the low EF, already you have diastolic dysfunction, or if there's myocardial disease, you already have it. The next step is to grade it. If E over A ratio is greater than or equal to 2, automatically you are grade 3. If it is less than 0.8, you are likely grade 1. If you are in between, then you have to look at whether the person has 2 out of the 3 parameters. So E over E prime average greater than 14, left atrial volume index greater than 34 ml per meter square, or TR greater than 2.8. If you have 2 out of the 3, then you have grade 2, or 3 out of 3, grade 2. If you have 1 out of the 3, then you move to grade 1. Then if you have 2 parameters only, 1 each, then you are indeterminate. So essentially, that is the new that's the 2016 recommendation for diastolic function assessment. The problem is that a lot of patients are unlikely to fulfill that criteria, especially for those even with normal EF. Majority of patients may not fulfill that 3 out of 4. Remember that tricuspid regurgitation can be physiological, and even if present, very few of them actually will have a well-defined regurgitation spectra for you to even trace or measure. And so it's not common in majority of patients who even have diastolic dysfunction. Now, with a left atrial volume index of 34 ml per meter squared, majority of patients may not fulfill that criteria of 34. And with E over E prime average greater than 14, you may have patients with diastolic dysfunction who may not fulfill that criteria. So there has been quite commentaries or critique on this algorithm, the 2016, whether it's been helpful. Some have proposed it has very low sensitivity in picking early diastolic dysfunction. And this sensitivity is better in those with advanced diastolic dysfunction, because the tissue Doppler usually may be normal until when it is advanced, before you may have reduction in the mitral or the lateral E prime velocity. So those have been some of the discussions, and that is why there has been proposal to use other parameters like the left atrial strain, the velocity in the pulmonary vein, systolic, diastolic, reversal, and other parameters. Basically, that's what I can say about that.
Thank you, Dr. Yusuf. So that brings us to
you can also share the document so that we can others can have it on the page. Dr. Eugene.
I'll do that, sir.
Okay, Dr. Amina, why don't you just take that? The person you want to speak. You can just read it out so that we can answer it together.
Okay, we can read it. I can read it. All right.
Okay, Prof wants to say something.
So there's more recent guideline that done 2026 and 2016. So there is, I think there is 2023 or 2024 guideline. So the focus is shifting away from talking about grade. The focus now is shifting to left ventricular diastolic filling impairments and elevated LV pressure, diastolic pressure. So they are shifting away from just calling it grade 1, grade 2, grade 3 now. They are trying to now specify, does this patient have relaxation problem and elevated filling pressure? So they're still using the same parameters that you quoted, but it's now to decide, is there elevated end diastolic pressure and is there impaired relaxation? You get what I mean, sir? So if you sit in the exam, they are already shifting away from grade 1 to grade 4 or grade.
Yes, Prof. I think it was in the British guidelines. But I'm yet to see the ESC or the AHA acknowledge that.
So they left 2016.
Oh, okay.
Okay, thank you.
Thank you, Prof.
So let's take Dr. Amina last question before we close.
Okay.
Dr. Amina, please, can you read?
Dr. Okupi, you said I should read the question 24 and we answer together.
Yes, please. At least we'll put our heads together. Those going for exams, so we'll put our heads together.
So which of the following, question 24, which of the following statements regarding the measurement of cardiac output is correct? A, In the thermodilution method, cardiac output is directly related to the area under the thermodilution curve. B, the thermodilution method tends to underestimate cardiac output in low output states. C, in the presence of tricuspid regurgitation, the thermodilution method is preferred over Fick technique for measuring cardiac output. D, a limitation of the Fick method is the necessity of measuring oxygen consumption in a steady state. And E, cardiac output is directly proportional to systemic vascular resistance. Over to the House. Hello, Dr. Eugene,
All
can
right,
you
so
hear
let's
me?
call,
Okay.
yeah, let's call on Dr. Asamoah to give an attempt, Dr. Eugene, then Dr. Charles, before we have comments from our chiefs.
Dr. Kopi, and unfortunately, I'm not familiar with the methods for invasively determining cardiac output. I'm yet to read on those. Thank you.
All right, so let's, Dr. Eugene, do you have an idea? Or Dr. Charles?
Dr. Kopi, I also want to read more on that.
Okay, is there anybody that has contribution towards it before we ask if our prof can throw light on it? Hello, Prof. I'm sure you're very good with this invasive stuff. I don't know if you can help us at all. We should take it tomorrow.
So seriously, so the methods, I'll just give us a kind of overview. So the methods for assessing cardiac output, we have both invasive and non-invasive. So the non-invasive is the use of echocardiography, cardiac MRI. Now, so we all know the formula for that in non-echocardiography. For that means you just get your stroke volume times the heart rate, be able to get the cardiac output. But when we talk about invasive, so there are different techniques for invasive assessments. So when one is using angiography, where you put your catheter in the picture catheter in the LV and you inject contrast, so you'll be able to get the end diastolic volume and end systolic volume by doing area trace, just like you do in Simpson. You do an area trace of that angiogram, both in systole and diastole. So we all know that if you have end diastolic volume and end systolic volume, you can get your stroke volume multiplied by your heart rate, you get cardiac output. So another method is to use the Fick's method, Fick's principle. So Fick's principle relies on a theory that when you know the amount of oxygen that gets to a tissue, you know the oxygen consumption of that tissue, then you can now deduce or estimate the volume of blood that has passed through that tissue. So if I know the oxygen concentration in the pulmonary artery entering the lungs, I know the oxygen capacity of that lungs, I know the oxygen concentration coming out of the lungs, that means in the pulmonary vein, then I can actually put a mathematical formula to get the volume of blood that has entered through the lungs. So that will tell me the cardiac output for that. So that's what Fick's principle method does. But the challenge with that is that, you just have to be sure that the oxygen saturation you're calculating is accurate, following all the protocols of ensuring the accuracy of the oxygen concentration you get. Because the moment the oxygen concentration, if there's a fallacy in the results, then you know that your cardiac output will not be correct.
And so that's the challenge with fixed principle, because it is oxygen to determine the cardiac output. Now, so thermodilution method tells us is another invasive form of getting cardiac output. So it tells you that if you know the temperature of a particular, if you know the temperature of it works with temperature. So if you know the temperature of a particular solute, a solvent, I use a solvent, entering the cardiac chamber, and you know the temperature of the solvent leaving the chamber, then you can interpret the volume of blood that has passed through that chamber. So in other words, directly estimating the cardiac output using temperature difference, or the temperature of the agent you use. So the agent we usually use cold saline. So it is a particular temperature. So in cold saline, you know the temperature that you are infusing through the central line into the superior vena cava. You know there's another catheter in the pulmonary artery that is measuring the temperature of blood leaving the right ventricle and entering the pulmonary artery. Then if we do the temperature, we know the temperature that's getting into the systemic circulation in the aorta. Then with that, we can actually, with the formula input, there's a particular formula for it, you can now get the cardiac output for that chamber. So that's just the basic overview of thermodilution, fixed method, and geographic method for assessing cardiac outputs. I think, Chief Okopi, I think that's one of the things we should do, is that we should just make it one of the, we usually take some lectures, right? So I actually can have some slides on that. We can discuss.
All right, sir. Okay, sir. Thank you so much. So, Dr. Eugene, please note this. Thank you so much, Prof, for this elaborate explanation. Dr. Eugene?
Noted, sir.
Oh, okay. So that we can take a lecture with Prof along this preparatory class. So we've come to the end of today's discussion. Many thanks and appreciation to everyone that came in today. We'll just do some house cleaning and then we'll be ready for tomorrow. Dr. Eugene, any announcements? So that we can call on Dr. Kweki and then Dr. Prof to close the class.
Thank you. I think I want to say a big thank you. This has been a good showing for day one, and I pray it continues on subsequent days. So we'll continue tomorrow. But I think Dr. Kweki will make the announcement since he's coming. We're contributing for the Zoom link. I think that is what one of the important things we have to try and get sorted out. Then we'll be having from next week, in fact, this weekend, there will be guideline presentations, and kindly refer to the WhatsApp page for the topics, and also note the date that you'll be presenting. Then that's Saturday and Sunday. We agreed on 6 to 8 Nigerian time. And so Saturday, Sunday, guideline presentation. Then next week, we'll do a presentation of the curriculum topic within 45 minutes as much as possible. Allow some 15 minutes for questions and answers, and we'll continue with the MCQs. So next week, let's be on time so that we can finish the curriculum topic and continue with the MCQ. Let's look at the timetable and prepare towards it. Thank you.
Thank you so much, Dr. Eugene, Dr. Charles Okorie, for a very wonderful anchoring of today. And also, just to briefly inform us that we're actually on Braunwald'S Cardiology MCQ. In case you just got added without having the book, we'll share it again. Please, let's also prepare that not only those going for exam that will be recruited to make presentations. If you're on the page, as long as you've listed your name, we'll call you up for presentations along the line. I'll call on Dr. Kweki before Prof will do a final closure of the class. Kweki.
All right, thank you so much. I would say that this is a brilliant start for being the day one of this presentation.